Hi. You are the first?
Yes.
Dr. Makato, would you be sharing your presentation or do you want me to share it from my side?
I connected the Zoom, so please present my videos.
Okay.
I think it's me. I'm more safer.
Okay. I would share yours then.
Yes, please.
Okay, so we start now. Good evening, everyone. Wishing you all a very happy sight day. Now, let's just proceed with this pediatric VR session. And it's my pleasure to welcome Dr. Inoue Makato from Kyorin Eye Center, Tokyo. He would be sharing his experience on retinal detachment associated with congenital aniridia.
Thank you for the kind introductions. Could you start my video, please?
Yes, please.
No working?
Somehow it isn't sharing from my side. Is it possible for you to?
Yes, I'm gonna try. Let's see. Somewhere
Okay,
maybe.
it got shared now.
Oh, okay.
Yeah.
Thank you.
Thank you for the kind invitation. This is Makoto Inoue, Kyorin.
Mhm.
So it's muted. We cannot hear the voice.
Right eye is a little bit shorter than the
Is
left.
it better now?
Yeah. It's
Yes,
better.
yes.
Let me just restart it then.
Yeah, please. We cannot hear it.
This is Makoto Inoue, Kyorin Eye Center, Tokyo, Japan. I'd like to talk about retinal detachment associated with congenital aniridia. This is my financial disclosure, but not related to this talk. Congenital aniridia is a rare genetic eye disorder with a total or partial absence of iris from birth. In most cases, genetic origin of aniridia is a mutation of the PAX16, leading to involvement in most eye structures. Photophobia is usually present and associated with reduced visual acuity and nystagmus. Aniridia-associated keratopathy, glaucoma, and cataract are pseudo-cell progress complications that have further reduced vision. And we report 2 pediatric cases of retinal detachment associated with aniridias. 10 years boy with aniridia cataract and mental retardation noticed decreased vision in the right eye due to the retinal detachment. Vision was hand motion in the right eye and 0.06 in the left. Ultra-wide fundal image indicating total retinal detachment with undetectable retinal break in the right eyes. Ultrasound image showing the total retinal detachment with diffuse corneal detachment. That may be indicated that the actual length in the right eye is a little bit shorter than the left eyes. Vitrectomy with lensectomy and silicone tamponade may result in bullous keratopathies in case of aniridias. Decided to perform lens pair vitrectomy with encyclic buckle. Vitrectomy was initiated. but retinal break were undetectable. Perflucarbon liquid injected, but posterior hyaloid and epiretinal membrane were not apparent. Then checked briefly, but subretinal fluid is not coming out. The working space of vitreous cavity is limited, so we decided to perform external subretinal drainage by 30 gauge needles. You can see the yellowish subretinal fluid is coming out from the needle. So we checked the periphery if there is any retinal break. So we found atrophic hole is located temporal superior areas. The atrophic fold is associated with peripheral proliferations. I tried to remove peripheral fibrosis as much as possible by the forceps, but you can see that atrophic hole is enlarged. So I decided to perform peripheral retinotomy by the vitreous cutter to remove all the traction. Until fibrosis should be removed enough due to the lens-sparing vitrectomy. Then perflucarbon liquid injected to drain subretinal fluid and fluid exchange, and laser was performed. Encircling buccal with silicone sponge was performed, and the SP6 glass was injected. Retinal will be attached even if difficulty to maintain prone positions. Cataract was developed immediately after 8 months, and the cataract surgery performed. After 1 year, vision was 0.1 in the right and 0.1 in the left. Ultra-wide image showing retinal reattached with cortical retinal break is located on the buccal. This is a 7-year boy with a history of congenital glaucoma and blue thrombus. The patient was referred for us for total detachment in the left eye with a vision with 20,000. The right eye vision had perception due to the congenital glaucomas. Ultrasound image showing the total detachment, but retinal break was undetectable. Similar to the first case, we decided to perform lens-sparing vitrectomy. The traction suture applied to the rectal muscle, vitrectomy was initiated. PVD was not present, and vitreous cortex is strongly adherent to the retinas. The retina is very mobile. PVD was created from the optic disc by the suction of vitreous cutter. You see the vitreous cortex is strongly adherent to the detached retinas. It separates gently. Further separation of the vitreous cortex might be dangerous, so we inject the perflucarbon liquid at posterior pole. With support with perflucarbon liquid, we found a retinal break at the inferior temporal areas. However, PVD was not created beyond the equator and beyond the retinal break. For the pediatric cases, it is very important to avoid iatrogenic retinal break. The stop to create PVD beyond the equator. Then peripheral vitreous is shaped with directing visualizations. But because this is lens-sparing vitrectomy, we have to think about not to touch the lens. Fluid exchange was performed, then subretinal fluid aspirated from the original break, and laser applied around retinal break. We also think about possibility of any peripheral retinal break. So end laser applied 360 peripheral areas. Because this case has a congenital glaucoma, peripheral visual field may be damaged. Then this eye is applied at the encircling buccal with silicone tire, followed with SL6 gas tamponade. Precipitous detachment was not present as was created, but no beyond the equator in the cases. The retinal tears are located infratemporal and slightly anterior to the equators. The retinal reattached positively, but IOP was just above normal level with full medications. Vision was red perception in the right eye and 0.04 in the left eye. Landerson described that review of congenital anirias. Ocular findings frequent in reduced visual acuity, reduced color vision, nystagmus, dry eye, anirial-associated keratopathy, and glaucoma cataract and dislocation, and foveal hyperplasia. However, association with retinal detachment is described only 2 case reports. One is the case of giant oral dialysis treated with encircling buccal. Other reports describe giant retinal tear in 4 eyes with 3 patients. This patient was treated with vitrectomy, lensectomy, and silicone tamponade. In this study, the original break in the first case is located in temporal superior areas. In the second case, the retinal break is located around the equatorial area in temporal inferior. We're not sure how our case is different from the previous report. It may be explained that PAX3 mutation is various. So conclusion, causative retinal break in the retinal detachment associated aniridia was various. lens-sparing vitrectomy in the encircling buccal appeared to be effective. We have a pre-registrational meeting from March 27 to 29, 2026. Online participation was free from the overseas. Please see in online next year. And thank you for your attention.
Thank you.
Thank you, Dr. Makato. Those were very challenging but very well managed cases.
Mhm.
So while I was going through all the videos that you showed in this presentation, it was very difficult, or both the cases had very difficult management of the posterior vitreous detachment. So I was just thinking, from a genetic perspective, do you feel that there is an association between congenital aniridia and hereditary vitropathies?
As you shown in this report, the previous report is a giant retinal tears, but our cases is different because two cases has that retinal detachment causing from the peripheral retinal break. So I think that this aneurysm is caused from the PAX16 mutations, but the phenotype is very variant.
Yes. Uh, Dr. Wood, your experience relating these congenital aniridia cases, and do you feel that your experience has been the same in case of in pertaining to the management of vitreous in such cases?
Yeah, first of all, I would like to congratulate Dr. Inoue for his excellent surgical technique. Handling these cases are very challenging. And as Professor Inoue mentioned, these patients usually have very tight vitreoretinal adhesion. Creating the PVD is difficult. So a lot of time I would prefer to use triamcinolone so that I could better visualize the relationship of vitreous and the retina. Also, the retina is very fragile, very thin.
Mhm.
So for me, of course, I like to ensure there is a PVD induction, but I probably would try to create PVD up to the equator. I would not force it anterior to the equator because in those areas, retina is super thin, and a lot of time the vitreoretina relationship in the posterior pole was different to the anterior retina, because in the anterior retina the vitreous actually take into the retina. If you try with force to create a vitreoretinal separation, a lot of time you would end up with retina break. So I agree with Professor Inoue's approach. In a lot of time, I would add a scale buckle to these kids. They could help support the vitreous space so that the successful rate would be higher. So, Professor Inoue, in your
Yes.
first case, the kids actually has the mental retardation,
Yes.
right?
Yes.
So it's difficult to have a good point position
Mhm.
after surgery for these kids.
Mhm.
So, but in the first case, you use silicone oil or gas?
Thank you for Professor great comment. Uh, Both cases I treated with that specific gas, but no silicone or tamponade, because we choose that the lens sparing vitrectomy. We inject that the silicone oil anyway we cause that progressive cataract. So that's the reason I choose that the gas tamponade. So even if that this case has mental retardations, I think gas tamponade works. Because I think it's because that the retinal break is not so large. I think that's the reasons. But thank you for comments.
Thank you so much. Excellent case, excellent technique.
Thank you.
So another concern is the management of lens in these cases, and both the cases that you showed, you managed very nicely sparing the lens. But as you mentioned, most of these congenital aniridia cases can have subluxations or cataracts or dislocation of lenses as well. So do you consider doing a cataract surgery or a lensectomy in the primary setting in a subset of these patients?
Thank you for comment. I think it's a very important point. Even if this patient has a cataract, the opacity is located in the center of the lens. So we can see that the retina through the peripheral clear areas. So we can preserve that lens, and even if the lens are a bit dislocated, we may do in the vitrectomy and the gas, and maybe secondary cataract surgery it may be better.
Right, right. Dr.
Thank you for
Dr.
comments.
Susanna is here. So, ma'am, any comments from your side on how you manage the lens in these cases?
Mhm. Excuse me, for me?
Dr. Susanna, please.
Susanna, you are muted. You are muted.
You will have to unmute yourself.
You are muted.
Well, so most of the times in children, I try to spare the lens because if you don't have the lens, you will have a very nice retina, but sometimes amblyopia. You can use the other eye for nearsighted, one for, but I prefer to spare the lens. But if for the surgery, somehow I have to make a decision of the most anterior membranes, and I in these cases I use the buccal, so I combine the vitrectomy and the buccal. But if I have if the surgery is not complete, if I cannot make the decision of this the membranes without sacrificing the lens, I can take the lens, but usually I try to spare the lens. And even when you make a tamponade with the gas or silicone oil, it's easier if you can have that separation from the posterior chamber. So I usually try to save the lens, and just if I cannot really address completely the retina, I sacrifice the lens. So usually the lens is very resistant to the maneuvers in the posterior chamber. I remember in ROP surgery, you can do a lot of things, long surgery, but you can still have a lens. Sometimes touch with the draw cards inadvertently, you can touch the lens, but the crystal lens, it remains quite transparent. So I try to save the lens in children as more as I can. If I cannot, I make the surgery and put an intraocular lens. Okay.
Thank you.
Monofocal. Monofocal.
Thank you. Thank you so much. So we come to the end of the first talk, and thank you so much, Dr. Makato. It was wonderful seeing your cases. And we'll now move on to the second talk by Dr. Anirudh Agarwal, and this would be moderated by Dr. Ahmed El Shafi. Dr. Ahmed, you can take.
Hello, everyone. I'd like to invite Dr. Anirudh Agarwal to be talking about his experience with tackling challenging detachment in pediatric dystrophies. It is very challenging cases, and would like to hear from him his tricks and tips in these cases, please.
So I would be sharing his presentation as well. Just give me a minute.
Hello, my name is Anirudh Agarwal. I'm at Cleveland Clinic, Abu Dhabi. Thank you very much to the entire team of Pan Ophthalmologica for this kind invitation. It's my pleasure to be at the pediatric VR session. And my topic is tackling pediatric retinal detachments, and I'll be focusing on Stickler syndrome and some other related disorders. These are my conflicts of interest. None of them are relevant to this presentation. So I'll be talking about some of the syndromes and genes, including the RS1 gene responsible for X-linked retinoschisis, the COL2A1 and COL11A1 responsible for Stickler syndrome, and one very closely related genetic condition with LEPRL1 gene mutation called LEPRL1 related retinal detachments. We also have COL18A1. This results in Knobloch's syndrome, an entity which is very common in the Middle East and this presents with retinal detachments and often macular pathologies like macular holes. Before we go on to retinal detachments, I'd like to start off by discussing my first case, which really presented with a different kind of a manifestation. This is a 2-year-old boy was brought with complaints of crossing of the left eye and difficulty in the near vision and an abnormal red reflex. Examination showed that the right eye had an ectopic fovea, a mild disc drag, and you can see some retinal hemorrhages near the inferior arcade. There was no obvious avascularity and no neovascularization was noted in the right eye. There were some hemorrhages also near the inferior ora. And in the left eye, the picture was more dramatic. There was a large tractional retinal fold. This was involving the macula. And there were some superficial retinal hemorrhages and ectopic fovea. And so, because there was no evidence of neovascularization, the child was kept under follow-up. And 3 months later, a repeat examination under anesthesia was performed. And you could see here, and the examination was highly suspicious of a bullous retinal detachment inferiorly with a possible inferior break. And so at this point, it was decided that we go ahead and perform surgery for this patient, also because this patient had a very large fold involving the macular center. So at this time, the patient was taken up for pars plana vitrectomy. And you can see here that this is the area which was suspicious and thought to be an area of inferior retinal detachment. And this is how the retinal appearance was. The vitreous in these patients is very typically optically clear. So with a standard approach of 3-port pars plana vitrectomy, pars plana vitrectomy was initiated and core vitreous was removed. And you can see this large bullous area inferiorly. Now, this was not really a retinal detachment. It was a retinoschisis involving the inferior retina up to the tractional fold at the macula. And so at this point, we decided it's very important to flatten the macular fold. And so we went ahead with a core vitrectomy. And in order to remove all of the hyaloid, triamcinolone assisted posterior hyaloid removal was done. And luckily in this patient, although was only a 2-year-old child, the removal of the vitreous was relatively easy. And so once the vitreous was removed posteriorly, shaving was done to remove all the vitreous from close to the retina and the periphery as well. And at this point, if we thought that if we have to flatten the macular fold, the only way is to really do de-roofing of the inferior bullous retinal retinoschisis. And so cautery was used to sort of demarcate the area, and all of the inferior retina, which is non-functional anyway, was excised and removed. And at this point, using Steno's diamond dusted scraper, we flattened the fractional fold involving the macula, and gas tamponade was given. And as you can see here, post-operatively, 3 months later, you can see that the fold is completely flattened and the inferior arcade is very easily visible. And this patient had a good visual outcome and brief reports. There are other similar cases, a large series by Mike Treasy, and of course also from the Japanese group regarding the efficacy of inner wall retinectomy for such large bullous cavities. My second case is that of a Stickler syndrome child. The Stickler syndrome really presents with large, giant retinal tears and often is bilateral, recurrent. And in these patients, it's very difficult to even prevent retinal detachment with prophylactic laser because sometimes laser itself can cause breaks and induce detachments. So this child presented with a left eye detachment. As you can see, there is some amount of vitreous hemorrhage as well, and the media is very poorly visible. And in these patients, my preferred approach is to apply a 240 band, 360 degrees, and I usually apply a relatively tighter and a higher band so that I have a prominent buccal effect. And I also perform vitrectomy in these patients, and in most cases, silicone oil tamponade is required because they require long-term tamponade. And it's very important to support the peripheral retina, and that's why they often require a high buccal effect to prevent future risks of retinal detachments. And this patient did well, and silicone oil removal was done eventually. And this patient unfortunately also developed a right eye retinal detachment. And you can see only a part of the retinal tear there inferotemporally, but really it was a huge retinal tear involving the entire inferior quadrant. And he also required a band and silicone oil in the right eye. Fortunately, the child did well after silicone oil removal as well, and the retina was completely attached in both eyes. This is another patient where there was an inferior retinal detachment from Stickler's syndrome, and he responded very well to only a plain scleral buckle. And so sometimes, if you have localized retinal breaks and no other pathology in other areas, sometimes plain buckle is a good choice in these patients. This is how the patient did. We have another case here of a 42-year-old man with multiple previous surgeries, Stickler syndrome. And this is the only seeing eye with extensive scarring. And he developed a fluid in the inferotemporal retina. Initially, we thought it's like a re-retinal detachment, but this patient underwent a fluorescein, and we suspected a vasoproliferative tumor here. And you can see on the fluorescein angiography intense leakage inferotemporally. So this patient underwent anti-VEGF therapy, and actually also PDT was done to this vasoproliferative tumor, and the patient did very well after that. So we have another patient here with multiple inferior lattices with Stickler syndrome, a large tear inferiorly. And in these patients, no matter how much laser you do, this laser was done here inferiorly. Again, this is a monocular patient, a very large inferior tear. Unfortunately, things just kept on progressing. And within a day or 1.5 days, she actually developed a huge inferior retinal detachment. And this patient required vitrectomy and oil tamponade, and actually did quite well. Finally, my last lepril 1 related detachment, very similar to Stickler syndrome. This patient is a 9-year-old girl who was brought for routine examination, and she did not have any specific complaints. However, probably this was due to amblyopia, and the detachment was mimicking again Stickler's, and again the same approach of 240 band and oil tamponade. And in this patient, because the break was very large and almost involving the 270 degrees of the retina inferiorly, I preferred to use a heavy silicone oil or Densiron in this patient, and this patient did quite well. And we have a number of publications of lepril 1, especially from the Middle East. So I think to summarize, pediatric retinal detachments with Sticklers and related disorders, often they require a band, and vitrectomy and oil. And very rarely, if it's a localized detachment, you can go ahead with plain scleral buckle. But these are difficult patients, and they require lots of care, especially prophylactic laser. In these patients has advantages and disadvantages, and they must be under very close observation for retinal detachment. Thank you very much. I'm happy to take any questions.
Great cases and very difficult cases. I think these are very, very challenging cases. And you mentioned the importance of scleral buckles in most of these cases. I think it's very important. The challenging in these, I want to ask you about the challenges and how you insist on inducing posterior PVD, and how important it is for you to have a clean retinal surface from the posterior vitreous face. Do you think it affects the prognosis of the cases later on? And if you have any tricks to remove this posterior vitreous face?
Dr. Anirudh, are you there?
Dr. Anirudh?
I guess he's somehow not connected, or probably getting connected. In the meantime, Dr. Wu, if you can take this question.
Sure. I think again, in these pediatric cases, the very successfully create a PVD is challenging. So you have to be cautious, be patient. But if you attempt multiple times, eventually you could make it. And to be able to visualize it, you could use triamcinolone sometime multiple times, because sometimes you feel you have successfully induce PVD, but actually they are
Hello.
vitreous species. They are not the real PVD because you pull one layer of vitreous up. If you restain it with triamcinolone, there is a layer of vitreous on the surface of the retina. So you could do multiple staining with triamcinolone. That's a trick. And also, in the first case, Dr. Agarwal showed a case of retinal schisis. I also like to adopt the technique of inner wall retinectomy. This is a bit controversial because some doctors advocate if you do it, it would result in even more PVR. But in our experience, it seems to be doing okay. But because these are rare cases, so we need to have more
Yes.
to support these observations. But overall, in these pediatric cases, I always access the possibility of using barcode alone. Whether barcode could result in good retinal attachment. That's my first approach. If that could not be make it, then I would use a combination of barcode and vitrectomy. And for the Stickler syndrome cases, prophylactic treatment is important. Right now, the most common way is to use a 360 laser, but the laser was somewhat different from our traditional way of laser around the lattice. Usually, these laser need to be adapted a little bit more posteriorly, even a little bit up approaching the equator or a little bit posterior. So it's more extensive because risk of the RD in the fellow eye also over 50%. So it's very important to adopt prophylactic treatment for the fellow eye in the case of Stickler syndrome.
So
I
Anirudh,
think I know your results now.
Yeah. Here, I'm sorry, I got disconnected at the wrong time. So I agree with
Yeah.
points.
The question was about the PVD and the tricks about the PVD that you can tell us about.
Staining is really the technique. So you keep staining, and if you have a doubt, then you should read with triamcinolone. Often it requires staining 2 to 3 times, and I generally tend to use those diamond dusted a lot. And sometimes, if the visualization is poor, still with triamcinolone, brilliant blue, dye also helps sometimes to visualize the remnant, hyaloid. So I think that's the only way: patience and a lot of hard work to remove the vitreous.
Yes, thank you, Dr. Susanna. Do you have any thing to add to us?
you
Yeah, muted, Dr. Susanna.
Dr. Susanna.
You are muted.
Yes, no, I'm unmuted. Would just add, because I had to speak with colleague, I just had some tip that is the first time I did retinal detachment for my child, then we redetached, and I was pretty sure I took all the hyaloid, but it was all there. So in this case, the stickler on those vitreoretinal degenerative diseases, be really sure that we took all the hyaloid, because hyaloid have schisis and have multiple layers of hyaloid. So you take one, what do you think, hyaloid, you induce posterior vitreous detachment, and then I stain again and sometimes again, just to be sure there is not another layer like in diabetics. So you have multiple layers of hyaloid because it has a hyaloid schisis. And it's a motive, it's a reason why you sometimes have retinal detachments, and more than that, you have contractions. I was pretty sure everything was out of the eye, but there was a contraction of that layer, and you have a contraction of the retina and the secondary retinal detachment. So be aware of the schisis of the vitreous in this kind of diseases.
Completely agree. Completely
Yes,
agree
yes,
with
yes,
this.
that.
Yeah.
I would like to add that beside the time serum, I usually use the beryllium blue, and as I use it in stage 4 ROP because it confirms for me the complete separation and having a clean retinal surface. It helps a lot.
Thank you.
Thank
So
you.
I guess now it's time.
Thank you.
Now it's time for us to move on to the next talk, and this would be moderated by Dr. Simar Ranjan Singh. So Simar, you can take over, please.
Thank you, Komal. Thanks a lot. And I think our next speaker needs no introduction to the world of pediatric retina, Dr. Waichi Wu from Taiwan. Welcome, sir. We already have had great inputs for you, and now we will be hearing on a retinal break in advanced ROP. What to do? Please, Dr. Wu, please.
Thank you so much for having me here. Can let me share my screen.
Yeah, please do, sir.
Can you see it right now?
Yeah, we can now, sir. You can go on full screen mode.
Okay. So what did you do when you have a break in handling the advanced RP with RD cases? I think this is the biggest nightmare for every retinal surgeon handling these tough cases. So in here I offer some tips for you. So actually, most of the time, retinal break in advanced RP with RD was catastrophe. It was reported that iatrogenic break could occur as high as almost 20% and usually associated with surgical failure. In here, I would like to share a case.
Excuse me, sir. Excuse me, Dr. Vichu.
Yes,
Your slide sharing is in just like next animation slide is coming also. So can you do one favor for us? At the bottom in the left bottom corner, in the left top corner, sorry, in the left top corner, there are a display setting in the left top corner.
in the where? In the
Above brief history, display setting, click on that.
Which
No,
one?
in the left side, top corner,
Top corner?
top. Yeah, above this, a display setting. Above this.
Just above the
Above,
time, you will have
just
display
above this.
settings.
Oh, show text bar.
Besides of this display setting, click on that. Yeah, click on that.
Which one? It's
Yeah, this one.
Click on that. Yeah, click on that.
there's a display setting, right?
Yeah, and then click on swap presenter view and slide. So yeah, thank you,
Is it
and apologize for
okay?
interruption, sir. Yeah,
Is it
it is
okay
Yeah,
right
coming
now?
now.
perfect.
Oh,
Perfect,
sorry,
Dr.
sorry.
Wu.
I'm
Please
sorry.
go ahead. Please go ahead. Please go ahead.
Okay.
Thank you so much.
So in here, I would like to share a painful case with all of you. This patient has a GA of 35 weeks, birth weight 1,530 grams. So it's not really small, but this patient have lots of issues like preeclampsia with IUGR, and she also have patent foramen ovary, RDS with COVID-19 infection. Also, she was found to have poor weight gain, and so these were all risk factors associated with the RP progression. And she was having noted to have active RP after, so she was giving bevacizumab injection at the other hospital, but it keep on get worsening. So this patient was transferred to us. So we did a surgery for these patients. So you can see that on presentation, the patient also had vitreous hemorrhage and a very atrophic retina, but retina was kind of retinal vessel was tortuous. We used triamcinolone to identify the triamcinolone, but accidentally there was retinal break noted. So we decided to use add a barcode and use a purple carbon liquid to drain from these two breaks and remove all the visual traction in that area. And we actually leave the pivocarbon in the eye for 3 weeks. Then 3 weeks later, we come back and remove the pivocarbon liquid and add more laser. You could see retina was attached at this point. And we have keep on following up this patient for over 7 months right now, and her retina remain attached. So here are do and don't from our previous experience. One is that if you have found out there's a retinal break, you could use triamcinolone to identify vitreous and try to relieve the traction surrounding the break as much as possible. And you could use short-term pivocarbon liquid to help stabilize the retina. And the baby could be placed in the supine position after the surgery. And you could add a sclera buccal to support the vitreous space so that you have less traction. And what I don't recommend to do was to use silicone oil. Why I don't recommend to use silicone oil in these cases? Because in the prior study, it has shown that silicone oil used in ROP eyes has very limited reattachment rate, but it was associated with very extensive post-op inflammation, perisilicone oil, perisilicone proliferation, scarring, secondary glaucoma, cataract, and keratopathy. And if any one of you are interested in ROP, there is an upcoming meeting. It's called World ROP Congress. It will be held in December 4th and 5th in Florence in conjunction with Flor Retina. If you are interested, you could scan this QR code, and I would welcome all of you to attend this meeting. We would also have a very intensive discussion on the surgical technique related to the advanced ROP. And I'd like to thank your attention.
Thank you so much, Dr. Wu. That was a very challenging case that you showed. If I could just get a few points. So in this case, you did not have much of traction. You primarily had vitreous hemorrhage, which you cleared out. And then you had, unfortunately, two breaks in the retina, which was relatively avascular at that point of time. So these were relatively peripheral breaks. When you have active stage 4A or 4B TRDs, and you're trying to dissect them, and if you have a break, what would be your tips for those cases when you're trying to do 4A and more of 4B cases? When there is a lot of traction along way, then there is no way you are going to get that hyaloid out. So do you have any tips for those, what you do if you have an unfortunate break? The first thing would be to not have that break. Yes, but if you have it, do you have anything?
Yes. So in our case, that day, on that surgical day, we tried the new vitrectomy machine without notifying me. So my suggestion not to try any new machine.
In children.
Okay. And also we have a new international fellow but that's not his fault. It's probably we still have some chemistry to work out. He is not too familiar with the assistance of such a challenging cases. But for these challenging cases, once you make a break, I think the first thing is not to get panic. You still calm down. Still, I think back to the basic, I would use the triamcinolone to identify the vitreous and do it multiple times. So I at least want to create a vitreous retinal separation up to a certain point. Maybe in these very young patient, difficult to reach as high as the equator, but I try to lift it at least, hopefully, at least outside the major vascular arcade. Then I relieve the vitreous dissection with my cutter, and I would use the highest cutting rate with with smaller suction force, so that I have minimum traction on the retina. Then I would put a barcode like this case, and eventually I would. Right now, I always use a shortened PFO tamponade. I I don't use silicone oil because silicone oil is terrible. It would only give you trouble without adding additional benefit for the patient's anatomic and functional outcome. With this approach, I could not say it's 100% successful, but at least a fraction of the patient could have a good retina attachment. And that's my advice if you make a break in the ROP cases.
I completely agree on the point of the silicone oil. So I have had a couple of cases in which with the TRD, I had a break while dissecting the TRD right at the ridge kind of. So in those, I felt that in the cases in which I went aggressively trying to detach the hyaloid, and then yes, silicone oil always a bad news. But in a couple of cases, once you release the anterior-posterior traction, and if you do not go about the vitrectomy very aggressively about the break, in two cases I've had my retina settle by itself because there was the anterior-posterior traction went away, the break went back, and because there was a gel vitreous around the break that kind of sealed it by itself, and that kind of had an atrophy around it, and it settled with time. So I don't know if anybody has had a similar experience with stage 4A and 4B cases in which you just don't do much once you have the break, especially around the break, and just relieve the anterior-posterior traction and leave it there.
Yeah, Dr. Singh, I cannot agree with you more because I found that for the regular cases, before you make a break, I actually do not do PVD in my stage 4A, 4B cases. I just release the traction. I don't use a suction force because the retina is super fragile. You could get yourself into trouble to trying to get PVD induction. It's not necessary, and it could bring in more harm than goods to your patient's eyes. So I do not do. You don't need to do PVD in those cases. You just relieve the major tractional vector. That's it. And once you finish, leave the eye as soon as possible. If there's an additional thing you need to do, you could always do it next time. If the eye, the retina was intact without any break.
Okay.
Completely agree with
Yes,
that.
really, we used to say less.
Hello?
Sorry. That's what we used to say, less is more.
Yeah.
So you just do the absolutely needed and leave it. If you are in risk, it's better you go twice to that eye. So go a second time to that eye, then make a break. So less is best. I once had a break. The first thing I did was to cut the retina when I get inside the eye, and I panicked. Sorry, Wu, I panicked. But I decided to do all the surgery. So I cut all the tractions, and the baby just had a retinal detachment 3 months later. Why? Because he had an injection, but he had also laser before the surgery. So I had injection, then laser, and then still go on having the traction. And then I went inside the eye, and I thought I was getting traction, I was getting retina. But because I think it was because I had laser, the retina didn't detach immediately, just a few times and 3 months later. And at that time, it was lucky. I could do a posterior vitreous detachment and attach the retina. But it was luck first. And second, it was the effect of the laser. So it was a very posterior retinopathy. I did laser. And I think that laser protected the eye from that crunch phenomenon when you make a break. But it was luck, absolutely luck. So I think we must avoid to make a whole. If we are in risk, less is more. That's my opinion.
Well, I agree, Dr. Susanna. Like recently, we
tips.
presented a case in IROP. I think similar case. Dr. Simmer was also there when he said, if you just find a break, if you just let it go back, it's always a
Yeah.
double-edged sword. It feels like everything is fine, and one day it'll stretch, and you all you see is there's a red kind of detachment. So it's always a double-edged sword. Once there is a break, you don't know what to do with it, whether to go ahead, release all the traction and create more breaks, or just let it be and take a chance whether it'll just go back or thanks Dr. Susanna for such nice inputs. And I think I'll go ahead and invite Dr. Susanna. She's a well-renowned pediatric retina surgeon from Portugal, and I would request you, madam, to give us a talk on your approaches on complex detachment in trauma, eye trauma. Yes, over to you.
Well, I'm going completely. Let me see if I can do it. So,
Yeah, we can see your slides.
you can see it. I'm trying to widen it.
Yes,
Oh,
yes. You
okay.
can just put it into a
So,
slideshow.
I thought it
Yeah,
was just
perfect.
one case, so I brought just one case. And sorry, it's not a huge surgical incredible case. No. So it's a close trauma, but gave me headaches. So it was an 11 years old young boy that was in a birthday party, and there was an explosion with that thing that make confettis, and it was right inside his eye. So he stopped, could not see for a moment, then went to the hospital, and it was in July. In August, everything was okay, said the other doctor, but suddenly, 2 months later, you had a drop of vision, and it was referred to me. Why? The guy, sorry, how can I go back? Okay, so when I saw this balloon trauma, so it was a closed trauma, no open trauma, it was sent to me, and I saw a partial angle recession, traumatic metriasis, a choroidal rupture around the optic nerve and pointing to the macula, commotio retina that I will show you, and choroidal vascularization. That's why they sent the young boy to me. In the OCT, we could see choroidal vascularization with active web activities. So I never had this in a child. I just had this in older patients, but not in a child. But I decided to do exactly the same. So I injected one with anti-VEGF, these choroidal neovessels, and 3 days later, it was the subretinal fluid disappeared. And I think, okay, we are in the good path. But what about now? How many injections do I do? Because this is not an old people, the macular degeneration. It's somehow a choroidal neovascularization of a trauma. So I decided not to make a protocol of 3 injections, but just 2 for PRN. So I decided to watch and see what's happening. So next month it was better, always with a little bit of fluid inside the eye, so a little edema, but the vision was getting better. So I decided to wait and wait. And you can see 3 months later, the young guy had 8/10 vision, although it has always those cysts inside the retina, some kind of activity. So from the 6th month to the 7th month, suddenly I had again activity. So I decided to inject again. And after the injection, everything was okay. So 2 injections, but always with that little bubbles, edema inside the eye. Usually we don't have much experience with this kind of trauma in child, just in adults. And sometimes in adults, I just make an injection and everything disappears. But I was amazed with this answer. So we could not stop the activity of this neovascular membrane. At this time, I could make a picture of the child. I could make a picture, and you can see the scar of the scleroptaria, retinosis scleroptaria, and you can see the brain. And here, with the pigment, the neovascularization. So I think we were in a good path. I go on seeing always you have the membrane and some kind of edema inside the retina. And I had a problem because at month 12, the vision was a little bit consistently lower, but the OCT was the same of the anterior. So I didn't know if I should inject or not, because I could not have physical evidence of neovascularization activity, but I had a dropped vision. I measured the neovascular membrane. I felt it was a little bit enlarged. So even that I didn't have new activity inside the OCT, I decided to inject. I don't know if I did it wrong or right, but I did it with this rationale. Then 13 months almost, right, and a very getting vision. And suddenly at 15 months, or even 1.5 years after, we could see during the observation, because I was taking observation of the young boy every month, he had a retinal detachment because of a dialysis. So when you think everything is okay, in trauma, you must always expect the effects, long effects of trauma. So I had retinal dialysis with the retinal detachment. I decided to make just a localized custodes link-off, just a localized sclerobuckle, and it was perfect. Now, during this surgery, I was very afraid that the neovascularization began again to have activity. So I did this buckle, and simultaneously I injected again anti-VEGF. So fourth injection of anti-VEGF. And since then, I have, so it's almost a year, I have no more activity of this subretinal neovascularization. But I'm always following this patient, because I really don't know how to behave. We don't have any study about these neovascular membranes in children. We have studies of these neovascular membranes in children secondary to inflammation, but not trauma. So it was a discovery to me. Now the eye can see perfectly, and the retina is attached, but there is no protocol how to treat this kind of membranes, how to treat this kind of problem secondary to a trauma. So, as we all know, ocular contusion can hurt all the tissues from the cornea to back. And those close injuries are very frequent in child, mainly in male child. You can have, because they are very active, usually associated with sports that can hit the eye. You can have those choroidal ruptures. It can be frequent, but usually you don't. It's very rare to have these neovascular membranes in children. So that's why I didn't know what to do, really. The treatment that we can see in the papers, not with a large number, but you can just observe. That's why sometimes people in the papers, they have this myth that the choroidal neovascularization in pediatric are self-involute. Perhaps the inflammatory, but not the trauma, I see. And we can use anti-VEGF laser, but I decided laser outside the macula, but I decided to do the anti-VEGF. But what I want to enhance, this is not usual. And so it was some kind of treatment ongoing, as I didn't know how to do it, as we don't have protocols. And in trauma, we must always remember that a trauma is in this time, but it reflects as a long time effects, and retinal detachment is quite frequent, and we must have a very wonderful eye, and 2 years later you can have mainly retinal detachment and also glaucoma. So that's the most frequent consequences of the trauma. So trauma cases give us a lot of work, because you can have, like in ROP, it's a for life disease. So this is the last time I saw the young guy. The neovascularization stopped, so no activity. It is with pigment, so I think just residual. But I brought this case, not a surgical one, but this case with a medical one, because it's very rare. And I think perhaps we could try to join all the cases of membrane, neurovascular membrane, that are secondary to trauma, that it's different from the inflammatory, that yes, that alone you can have papers and series about the neovascular membrane associated with inflammatory cases, but not with trauma. So trauma is forever. It's a patient that we must see forever, because we must always screen glaucoma, retinal detachment, and this problem, choroidal neovascularization. So it's not a surgical one, but I think it's important to speak about these rare cases. And it.
Thanks.
Yeah,
I think
yeah. It was a great presentation, Dr. Suzanne. Just one quick question. Would you alter any dose of aflibercept in the child also?
Couldn't understand. If I what?
No, did you alter any dosage of aflibercept in the child? I mean, in a
The
pediatric.
dose of aflibercept, I use the normal dose because he was 11 years old, so it's a normal eye. The size of the eye of the
Right.
posterior chamber, it's the same.
Okay,
So I
I
use
the initial.
0.2, 0.05. The only problem was during the surgery, because I didn't want, you see, there was not much subretinal fluid from the retinal detachment. So I was making paracentesis during the surgery just to be able to buckle as I want, not to drain, because I could have more complications draining the subretinal fluid. But so I was doing the paracentesis to make room for the buckle and room for the 0.05. But I was able to do it. But you have to do quite a few paracenteses just to be able to do all the surgery. But the concentration of aflibercept was the same. Aflibercept 2 milligrams, 0.05. So.
Nice.
Sushma, could you lead the discussion?
yes, sure. Dr. Susanna, I had one question, especially when I saw that the kid developed a dialysis. So, when do we do the examination under anesthesia? What is your protocol? Because obviously, examine the kid without anesthesia with an indentation is always a challenge. So, what is your protocol? When do you think we have to consider EUA? What are those specific cases? And when do we do it? The duration, which ones, and when?
Well, it was, how can I say, it was surprising to me, because he had a traumatic mydriasis. So it was easy to me to see all the time the eye of the child. And as I injected, I'm obsessed and I saw this dialysis. So it was really surprising to me. In young patients, I perform, it depends on the case, but I see the babies and general anesthesia. This one, as I saw so well, and I saw really, I could not ever find the dialysis, perhaps I should have put a contact lens, because he was 11 years old and it allowed me to do everything. But it's some warning that we must have. This is more frequent than we imagine. So when I cannot perform the you don't have to make indirect ophthalmoscopy with indentation if they are grown up. You can put the three mirror lenses and do it and see it perfectly. And this is really, I miss this. As it was in mydriasis, I thought I saw everything. I don't know if it was because of the injection. So I did the third injection 1 month before. So perhaps there was some kind of contraction of the basis of the vitreous that traction the dialysis. But I don't have absolutely, how can I say, a protocol to look at the dialysis. But I think we must really create some kind of protocol about this, because it can, as I used to say, you can hit your end. So it's very important to look at those peripheral dialyses, mainly temporal inferior or superior nasal superior, just associated with the trauma.
Otherwise, also it looks like a myopic eye, which
No,
has
it's
all
not.
the yes, yes,
No,
it
it's
has a.
not. Look, the
It's
other
not.
it's very blonde, so it's
Okay.
very light, young
Okay.
guy.
Okay.
Has no myopia, needs no glasses to see this
Mm-hmm.
this 8/10. This eye is 10/10, but this is a little bit less, but consistent.
Yeah.
But has no myopia. It was really the trauma, a very violent trauma. It was a shotgun in the eye, not a gun,
Yeah.
but this kind of devices to pump up the confetti. But they are some kind of very pressurized, the very pressurized device that can hit you and do like this. Yeah.
Dr. Komal and Simar, any thoughts on this kind of case with a choroidal rupture? Because you guys see a lot of kids too. So, have you encountered this situation in your practice?
Yeah, definitely. So I think MNVs with the choroidal rupture we do see very frequently. A lot of times with the choroidal rupture, especially on OCTA, you would keep seeing that network sometimes. But yes, I would want to look for activity before I decide on injecting in such a case. With that, many times when you suspect that there might be a MNV, you get an octa done. There is no fluid, but there is a network there because there is a choroidal rupture and you're seeing the choriocapillaris probably through it. But yes, with activity, definitely injections would be the way to go. And usually they would quieten out with a limited number of injections, don't require them for a long term.
Dr. Komal, do you think, do you consider FFA? Do you consider FFA? How often do you do angiogram before? I mean, if you have seen.
So honestly, with this kind of cases, I guess the use of FFA is quite limited, at least for me. I believe OCT would give us a good enough idea. I would say again for the activity as well, it's not really like a myopic CNVM where, the OCT will just show very little fluid or might not sometimes show any fluid, but the patient is still symptomatic. That can quite happen with the myopic CNVMs. But in these cases, I guess for me, OCT is enough.
Thank you.
I think so also.
Can I have a
What
question
also
for Susan?
amazes me, what also intrigues me was the fluid always. So it has a very good vision, but you have always little fluid inside the retina. So, but that's not a motive for me to inject, just to observe. But it's strange. So I'm keeping seeing this young boy.
Dr. Wu had a question.
Yeah, Susan, great case, very successful treatment, and with very good visual outcome. So, if I just look at the fundus photo, if you make me to make a guess, I would not say, oh, this patient could achieve a vision of 6/10. I think it's challenging. Do you think that
Very.
this patient develop certain kinds of atopic fixation? Do you check it or?
No, if you look, let me go. If you look before, so it's just the foveolar. I mean, this side of the fovea, it's very well, very good. And this one is the one who has the problem. So part of the fovea is okay. That's my interpretation. And the other part is not. You see, this part of the fovea is okay. And that one, so the nasal one, is the one who has this problem. I tried all the way. So with numbers, I thought, no, he already know the letters because he's very smart one. So let me try with the numbers. And he has 8/10. And let me try with, again, the is, up, down, different things to be sure, because I thought, no, he's cheating me for sure. But it's not. So we can see, he sees that, and my interpretation is this half, this half of is free of problem, and you can make somehow see the letters, sometimes letters from the left side of the where we projected the letters, but he can see all the letters, all the numbers, so it's not cheating on me. My interpretation is this side, you see, this side is okay, and the other side is not.
Got it.
I cannot, because extrafoveal fixation, it does not give you more than 3, even microstrabismus can give you 6/10, but not 8/10. So I think really half of the macula, because it's a child, half of the macula is free. The other half is not, and that's why I am very worried about these little cysts. Perhaps the choroid that had the fracture doesn't work so well. And that's my interpretation. It's not vascular activity. I think it's really the choroid that it's not very good in this because of the fracture or of the trauma, not because of activity of the membrane. But really, it's a surprise to me, and it was very difficult to know how to treat him, as we don't have protocols, how to behave to this membrane.
Yeah,
and I'm still
always
looking at a
surprised.
young boy.
That's an amazing
But
case.
yes, they are surprised.
Great
So I
case.
had a different set of questions, thinking that you're going to, have a traumatic detachments, and I'm going to ask all these questions. But you completely surprised us with this beautiful case. This can also happen in trauma. It was like an eye opener for all of us. So I think any other comments? Then otherwise,
Because the retinal detachment and all that, we all have retinal detachment. We all, the struggle, and then suddenly a little membrane can take me off of my head. That's why I decided to take it and bring it.
Thank you, Dr. Susanna. That was a wonderful, wonderful case. We would move on to our next case, and I would invite Dr. Neha Khanna to please moderate the session.
Yeah, thank you, Dr. Suzanne. It was really a very different case as expected. And now I welcome yeah, actually, we all were thinking in a different direction. Yeah. So, welcome Dr. Mariam, who is an assistant professor of ophthalmology at Ain Sham University. And she has an active researcher with the notable contributions to intraoperative OCT and retinal imaging as well. So she's going to present us the buckle in retinoschisis and FEVR cases. So, Dr. Mariam,
Okay, yes, can you hear me?
Over to you. Yeah, ma'am.
Okay, thank you so much for the invitation. I will share my screen here. Can you see the screen?
Yes, ma'am.
I'm not seeing it.
Yes, screen, but it's, yeah.
Okay, just a second. I think I have to make it like this. Okay, now we can see the screen, right? Can you see the cursor also, please?
Yes, we can.
Yes. Okay, so I will be talking about buccal as a management option for retinoschisis and familial exudative vitreoretinopathy. So my first case is a regular 7-year-old boy presenting with bilateral X-linked retinoschisis. He presented because the right eye was lost for a long while from open funnel retinal detachment and visual acuity was hand motion, and he's now presenting with the left eye having again retinal detachment, as you can see inferior with the retinoschisis. And from the right eye, I could find where the break, because you can see the break here in the outer leaflet. In the left eye, I didn't know where the break is, but I assumed it would be in the same area. I did an examination under GA. I didn't find any breaks, but I decided to do him a buccal. So that was a regular buccal, tire 180 degrees and the 360 band, and he was doing fine, and the visual acuity improved to 0.05. Now let us go to the next cases. So my next case is a 5-month-old girl with familial exudative vitreoretinopathy. Her left eye has a falciform fold, as you can see, and the right eye, the better, in my opinion, had this tractional retinal detachment with an area of retinoschisis within the red dots, as you can see here. So for the primary presentation, we decided just to wait for a while and follow up the case to see what the pattern, what would happen in this eye. And she suddenly came with a progression in the retinoschisis, as you can see, after 1 month. So we decided we will operate and relieve there is actually fibrous proliferation in the periphery here at the ciliary processes, which is dragging the whole retina anterior. So we decided to do an lensectomy vitrectomy for this case. And this is at the end of the surgery. So at the end of the lensectomy vitrectomy, you can see that the retinoschisis pocket has completely regressed. The retina looks okay. I will be doing, this is the area of the retinoschisis here. You can see it is demarcated a little bit. And with the indentation, we can't find any breaks or anything. Everything looks okay. So we terminated the surgery for now, and I'm following up the case for 10 days. Everything looks fine, except that there was a small red dot at this area, which suddenly, after 10 days, developed to be a break in the outer leaflet, which is enlarging with the flattening of the retina. So what shall we do now? I did an OCT to confirm, and I know the resolution is not the best because she was awake and moving, but there is actually a break in the outer leaflet. So I thought, let us go for a laser photocoagulation or a cryo around this area. But when she came the next day, the retina was already shallow detached. So I have to do something else, and I decided to do a radial buccal over the break. And you can see here the break, and I'm doing a cryo over this break. It's in the outer leaflet. It's totally sealed inside. Maybe that's why the buccal worked with a vitrectomized case, because I already have an inner tamponade, and this is the radial buccal at the end of the surgery. And again, everything is going fine. This is her picture after 5 days. She's doing great. And then suddenly she came again with another detachment here, and looks like there is another break in the outer leaflet at this area, because the retinoschisis was like going up to the fovea actually. So in this time, we decided to go for a circumferential buccal. This is the intraoperative OCT. You can see here the break in the outer leaflet at this area I was showing before. So I decided to do a circumferential buccal, as you can see, and now I put a gas tamponade. In the first one, I just put a radial buccal and I didn't put any tamponades, but in this time, I put a gas tamponade to push all the fluid if there is any outside. And this is the picture of the case 9 months later. I know the fovea has been actually distorted, but she can see with this eye because this is the only seeing eye, and actually she is catching objects well. So my next case is an 8-month-old with, again, familial exudative retinal detachment, and this is his right eye presenting with atrophia, and the left eye presenting again with the tractional retinal detachment, and there is actually tractional force here again at the ciliary processes and causing exudative retinal detachment also. And this time I decided I don't want to go for a vitrectomy. I don't want to have another disaster at the previous one. And we decided to put a segmental buccal, segmental circumferential. So this is a sponge, 180 degrees, and this is a picture 1 week later, and this is a picture after 1 month, and this is the picture after 4 months, and he started to catch objects by this time. But this child came to me 1 year later, that was like a month ago, and he developed redetachment because the eye is growing. So I decided to put a circumferential buckle, and now he's doing fine. So the retinal leaf flattened again once I put the circumferential buckle. So it's just that the traction is causing the detachment to recur when the eye is growing. So I decided to put the circumferential to stop the growth of the eye because the axial length actually reached 20 millimeters, which is okay. My next case is this is the last case. It's a 1-month-old boy again with familial exudative vitreoretinopathy with this falciform fold. We have here a fibrous proliferation, neovascularization at the bed, and you can see here the neovascularization in the bed in the fluorescein. All this is a vascular retina, and this is the only vascularized retina. So actually, I didn't know what shall I do. I gave him an anti-VEGF as a start to stabilize the eye. And then 1 month later, I decided to put him a segmental buckle over this area and do cryo over the areas with the neovascularization. This is the picture like 2 days after or 1 week after the surgery. You can see the exudation is much obvious after pushing it anteriorly with the buckle because I put the buckle to push the eye. So on table, I can see all this exudate coming to the base of the buckle. And this is the cryo applied here. But you can see here the follow-up of the case with the exudation regressing slowly over several months. And this child started again also to catch some objects with this eye. I don't know if this is okay, but it is doing fine for now because we don't know how to manage actually those cases for sure. So my take-home message is that buckle can be safe and salvaging option in several cases of retinoschisis and fever, even in the vitrectomized eyes, and we have to give it a try. Thank you.
Very interesting cases, Dr. Mariam. One question that do you think that in the third case, I believe that initially only we would have gone for the circumferential one. I mean, would that decision be a wrong decision initially? Instead of going for
You
the
mean I should have put a buckle as a start,
circumferential, yeah,
not a vitrectomy?
The case where you have initially put a segmental in the radial buckle and then it came for a detachment and then we had undergone for the circumferential later on.
Yes, that's because the eye was very small. I thought if I put a circumferential, I would have to go and cut it to let the eye grow. So I put a very high segmental, and it was doing well for like a year. So I thought we are done with this, and then suddenly the eye started to grow. That's why I thought I should have done the circumferential from the start. But that's why I put the segmental to allow the eye to grow slowly. But with a high buckle on the area of traction, maybe it would make fine, but it didn't do. Yes.
Right.
Yes.
And also another question, like in all cases of FEVR, would we like to use the anti-VEGF as a preparatory one before vitrectomy?
No.
No.
Actually, this case, I didn't know what to do. And I don't think there is a lot of literature in the literature about this picture. And this is, again, a single-eyed patient. So this is the problem. If the other eye is doing fine, usually those eyes we don't do a lot for them. But when he's a single eye, the other eye is atrophia. So I cannot just leave this eye to go into atrophia also because you have a lot of neovascularization at the base. So
we do take care of the other eye as well simultaneously. I mean, any protocol to follow that? The other eye.
To follow.
The protocol
The
to
other
follow.
eye is actually a lost eye. He presented with one eye lost with atrophia, and this should be the seeing eye.
Right. No,
this
otherwise we see one patient, one eye with a detachment, and other eye still in the salvageable.
Yes, if I have this and I have a peripheral avascular retina, I laser it. I don't leave it. So in those cases, I usually laser that, except if the parents refuse, because sometimes the parents will say, I don't want to interfere with the other eye if it doesn't have a problem now. But usually I do a laser for the avascular retina in the other eye if the other eye is the better one. Yes.
Right. Anyone else's opinion on this?
I would just like to ask something, Dr. Mariam, especially for the last case, the kind of cases that you've shown, which has a tractional along with either a reg or a exudative component. Yes. So have you or do you have an experience of doing scleral imbrication in cases like this?
And no, I don't have an experience with scleral imbrication actually, but maybe it would give the same effect of the sponge. Maybe it would give the same effect.
Yeah, so basically, we used to do for cases like this specifically, we would prefer probably doing a scleral imbrication along with a high buckle, which would give us the scleral shortening as well, and along
Yes.
with the high buckle height. So, to sort of stabilize the area of the traction and the fold that is there.
So what I do actually in those cases that I take broad bites around the sponge to make this shortening effect. So because the sponge has it's better than the band that it can like make a deep indentation, and you can take wider sutures and it would not cause like corrugations in the sclera or something like this. So I take wider sutures.
Right, right.
I
Thank
just
you.
wanted to ask Dr. Mariam, when you're doing such cases, the one that you are projecting right now, do you do cryo along with to the base or just the buckle?
So yes, I did a cryo on the base. If you can see here, there is a cryo
Yeah.
here over
Yeah,
the
that is
base.
what I wanted to
Yes,
know. That's the so that would kind of take care of the activity. So despite the fibrosis, you would advocate doing cryo to the
I did the cryo on the base, not at the area of the fibrosis is anterior, and I went
okay.
deep. I opened the conjunctiva deep as because I'm putting the bucket actually, but I put
Yeah.
my cryo probe very deep and slowly getting from the posterior to anterior and doing just one cryo shot, and just like once it is getting white, I stop. I don't do over cryo. Yeah.
Right.
Very
Thank you.
gentle. Yes. Thank you
Thank you.
so much.
Right.
Uh,
Any other questions from the members?
So, thank you everyone for being
So
present.
do you have some time? Can I ask a question to Dr. Wu?
Oh, yes,
If
please
we have
go.
some time?
Yes,
Yes.
yes.
So for the case with a break, you said you put. Is he here, Dr. Wu?
Yeah, yeah, he's here. Sir's here.
Okay. So you said you put PFO. So how long do you keep the PFO inside the eye?
As short as 2 weeks, but sometimes it could be up to 4 weeks because
So,
sometimes I schedule removal of PFO, but the kids was unstable for the surgery.
yes, I see.
So sometimes
So
we could not remove it as we planned to, but it could be around from 2 weeks to 4 weeks. And I didn't
I
see
understand.
I didn't see significant inflammation in these eyes. So it should be well tolerated.
So if you put silicone oil, because I have an experience with the silicone, if you put silicone oil for a short while, like 2 weeks also, it doesn't cause a problem with the residual hyaloid. Actually, I have like 2 to 3 cases with this. I didn't leave a PFO because I didn't know this, but I used to put like silicone oil, not full fill as you do, and just go after like 10 days or 2 weeks if the retina is fine and the laser is fine, and I remove it. And they actually do fine. They don't. If you leave it for a long while, yes, it would make a problem. But
Yeah,
if it's a short while, maybe.
yeah.
Once I put a Helon, just Helon, because the retina was flat. It was a break on a flat retina, so I just lasered and I kept the eye with a Helon because not to keep it with fluid, and like air, something like air, and it did well also.
Yeah, if you leave it for too long, it would definitely cause a lot
Yes,
of complication. I
I
agree.
see.
If you remove it as soon as possible, like you said, 2 weeks. But I found it's very difficult to do that within 2 weeks because these retina, unlike the rheumatogenic retinal detachment for adult population, their retina was not completely dry yet, and the traction was not
Mm,
completely relieved yet, because we couldn't do that in kids' eye. So for
I
under
see.
I like the the use of PFO to help stabilize the retina better because it's heavier. It could have an
It
effect
will dry it more.
support, yeah, to support the retina. But the
I
silicone
understand.
oil is lighter, okay? And in those eyes, you cannot have a full fill silicone oil. So silicone oil maybe 80% or 90% fill. And
Yes, yes,
for
sure.
patient usually supine position. So you would not have good tamponade effect because
I understand.
the silicone is floating. Yes.
And when do you remove the PFO, you put another tamponade, you put air, you put gas, or what do you?
Usually, no, just perhaps room
Just
air.
fluid?
Yes, just room air, or
Air.
just
Okay.
nothing. Yes, just remove
Okay.
it. Yeah.
Okay. Thank you.
Okay,
Thank you so much.
we're
Nice
coming
case.
to the end of the session, and thank you so much, all of you, for wonderful insights and wonderful discussion that we have had in this pediatric VR session. So we would close here, and I guess the host will take over for the next sessions if they're there. Thank you, everyone.
Thank you so much.
Thank you so much.
Bye
Thank you,
bye.
Kamal.
Thank you.
Bye-bye.
Bye.
Bye. Thank you.
Thank you, everyone. Thank you.
Thank you. Goodbye.
Hello, everyone.
Hello, hi.
Starting our next session. So a very warm welcome to this Pan Ophthalmologica webinar on this World Sight Day. So over the next hour, we'll be hearing from some of the greatest surgeons and innovators in our field, and we'll be very excited to listen to your talk. So get ready for an insightful and dynamic session. Okay, so without wasting much time, I would like to invite our first speaker, Dr. Magno Ferreira, who is from Brazil. He's serving as a professor of ophthalmology at Federal University of Berlândia. He was the past president of Brazilian Society of Retina and Vitreous. And with a deep commitment to scholarship and education, Dr. Ferreira has authored numerous articles and book chapters, and he has been an invited speaker at multiple international congresses. And he would be talking about the retinal detachment in high myopia today. So over to you, Doctor.
Thank you very much for this very kind invitation. It's a pleasure to be here talking with people from all over the world, and especially from India. And very nice invitation from my behalf. Thank you. I'm going to share my screen. I think that the best way to do it is going to be this way, because sometimes cut the size. I'm going to present a managed retinal detachment in high myopia. I have no financial interest for this presentation. What is high myopia? The definition is spherical equivalent less or equal -6, axial length more than 26.5 millimeter, associated with degenerative change of the eyeball, especially in the posterior pole. The prevalence is 1 to 2% in the United States, but may be up to 10 times higher in some regions of Asia and Middle East. Incidence, 50% increase in retinal detachments over the last 16 years. Myopia, 82.1% of fake detachments under 50 years of age. Changes results from increased axial elongation. Myopic traction maculopathy, it involves a split or separation of the retinal layers in the macula. Two forces has action in this kind of situation: AP, vitreous, tangential ERM, and ILM. Posterior pole staphylomas, it leads to MTM, foveal skis, macular hole, and retinal detachment associated with these pathologies, and retinal detachment. The refractive error and retinal change. If you have -2, you have 2 times more chance of getting MTM and 3 times more chance that getting retinal detachment. -6, 41 times more MTM and 9 times more retinal detachment. -8, 127 times more MTM and retinal detachment, 20 times plus more retinal detachment. Symptoms: asymptomatic in early stage, gradual loss of central vision, metamorphopsia. Diagnose: you can use the OCT to show the split of the retinal layers, as you can see here, and can help access traction components: AP, vitreous, tangential, ERM, and ILM. Related conditions: myopic macular hole, foveal skis, retinal detachment, and high myopic epiretinal membranes. Surgical challenges in high myopic patients. Great axial length, posterior staphyloma, thin and more atrophic retina, degenerate vitreous, thin sclera, abnormal scleral fiber architecture. To mitigate this problem, you can have some different probes. Alcon has one probe with 23 gauge with the axial length of 31.75 millimeters and forceps 23 with 32 millimeters. Torque has a special 23 gauge for high myopic with 40 millimeters to use for these special situations. Treatment depends on the severity. Observation if vision is still relatively good and no progression. Vitrectomy surgery for progressive case or if a macular hole or retinal detachment develop. Here we can see the first case. The patient has MTM, macular hole, and retinal detachment of the posterior pole. For this case, we start with detaching the posterior hyaloid until the mid-periphery, use triamcinolone to do that. We try to remove the hyaloid as much as possible. As you can see, that patient has a big staphyloma in the posterior pole. I didn't use special forceps for this situation, but I used the 23 forceps for do this kind of situation, even though most of my case I do with 25 plus probe. This I am using peeling the hyaloid, the ILM, using the Eckert forceps. In this situation was not that difficult because the patient had a posterior pole retinal detachment, what facilitates the maneuver in the posterior pole. I'm combing the macular hole region with a tunnel scraper. And I did after that FAX and finished with C3F8. The patient evolved with a retina attached, but unfortunately, the macular hole was type 2 closed. So, the macula was flat, but not closed in the central area. And the vision was poor, 2400 at the end. The second case, it's a patient that has, it's a more complicated patient. It's the only eye. In the left eye, she had type 2 NVM, and in the right eye also she had type 2 NVM, and she has a scar in the macula, but nasal area of the fovea. I tried to do the peeling, but I could not, and then I decided to do autologous retinal transplant for this situation. I did I cut the retina in the superior retina, but normally I cut in the inferior or in the nasal, but because the eye was too big, it was very difficult to do that in the inferior or in the nasal area, and I decided to do that in the superior. The problem is sometimes you got bleeding, and the bleeding can go underneath the fovea. The OCT after this removed the silicone eye, the macula was attached, the macular hole was closed. The vision varied from 26 to 28 because the patient had recurrence of type 1 neovascular membrane, and I am treating there with faricimab. In summary, consider surgery when progressive decrease in visual acuity despite conservative monitoring, alter retinal detachment, subretinal fluid beyond the sky's cavity, development of full thickness macular hole sometimes occur as a complication. Foveal architecture worsen on OCT, such as increased sky's height or lamellar hole progression. Symptomatic metamorphopsia, significant affecting daily life. Thank you.
It was really very fascinating talk and wonderful surgery, doctor. So I
Thank you
just
very
want
much.
to ask that you showed a few specific forceps for and instruments for the surgery, right? For the especially when the axial length is more than 30 mm. So what is your personal opinion when we don't have such kind of an instrument with us? What adjustments do we make for the safe surgery over posterior pole in such cases?
What I think that you can do in this situation is just instead of put the incision, the trocar 3.5 to 4 millimeters, you can increase to 5 millimeters, 5.5, and then you can have access more easy to the posterior pole and to do this kind of surgery. Because if you don't have, normally we don't have this special force. And we have to do something. I think that one of the best, or sometimes you can even if you do that and you cannot have access in the posterior pole, you can remove the trocar and get inside the sclerotomy instead to have the trocar for this, especially only for this time of time of surgery. I mean.
Also,
And,
we
what
can
is
do
your
some.
yeah,
Also,
please.
we can do some create some hypotony. Then that will also help you to reach the posterior pole.
That's right. Sometimes you can decrease. I use normally the IOP pressure of 25. In this situation, I can go down to 10, and then I have more easy access to the posterior pole.
So, sir, before you're inserting at 5 mm, like, do you indent and see, or you just do it? Do you have any algorithm for at what place you should insert, like in these high myopes? Like for high myopia, like let's say 10 minus 10 diopter, you will insert at 5, 5.5, and at minus 5, minus 6, you will insert at 4, 4.5. Do you have any algorithm, or you just it's like it's a fixed, or do you indent and see? Where is the retina stop?
You know, one thing that is really good to do in this situation is just maybe if you have a total retina that you cannot measure the axial length if you don't have this previous. But one good thing that if the patient had the same myopia in both eyes, you can measure the axial length in the other eye, and then you can guess if you're going to need something special or not. If the patient has 26, 27. I think that you'll be okay to do the normal surgery there. But if the patient has 30, 31, and then you have to plan something in advance to get to solve this, to mitigate this problem during the surgery. I mean.
No, I wanted to ask is whether you indent and see the aura before you take, before we deviate from inserting from 3.5 to 4 mm. Do you insert, and you said that you can insert at 5.5 or 6 mm. Then do you indent and see the aura, or do you are sure that it will be at the aura will be beyond that? Are you sure about that?
I think that until 5.5 to 6 millimeter, I think that you can, it's if you want to make sure that you are not getting underneath the subretinal space, you have indentate to see if you are doing that in the normal way. But normally, I think that you'll be okay if you do that 5.5 to 6 millimeter. I don't think that it's not a problem at all to do that. Normally, I don't check the aura for this situation.
Right, sir. Your case of posterior staphyloма, it was also quite a good indication for macular buckle also.
Yeah, macular buckles is a good. I think that will be another option. I think that I will reserve the macular. I don't have experience with macular buckle. I know that Barbara and a few people around the world has good experience with that, but I normally will try. I will go to the macular buckle if the surgery the vitrectomy failed. I have to, and sometimes I will refer to another person in Brazil to do that because I don't have really experience of doing the macular buckle.
Right. And what is your preferred technique in macular hole RD in this case, high myope cases? Like, do you do simple peeling or you do inverted flap, or it depends on the case?
I think that inverted flap is a good option always. But for these high myope patients, sometimes it's very difficult to do even the normal ILM peeling. In this situation, in the last case, the second case, I tried to do the ILM peeling, but was really very, very tough, and I could not do in a normal way. And then I decided to go to autologous transplantation, or maybe a mini-arc membrane. It's another option for this kind of case. But if I can do a very nice peeling, I do the normal peeling or the inverted peeling. I'm doing for macular hole over 800. I think that is a very good option to do the inverted ILM peeling. I am doing that for many cases, for big holes, not for normal one. Until 650, I think that it's okay to do the normal ILM peeling that we have been doing for many years.
Sometimes when we try to stain this ILM, because of the overlying traction, this dye dissipates into the subretinal space and we lose all the contrast if the dye goes in the subretinal space when you are injecting. So what are the precautions that we should take, sir? Like, do you stain it under air or do you stain it under PFCL bubble or something like that? Because sometimes the dye in these cases does migrate subretinally. And I also saw that in your first case that you didn't do an inverted ILM flap. You did a lot of massaging with the Tano scraper, right, sir? So
yeah, I did. I think that normally I don't. I under the brilliant blue. What I use the dual stain. It's a brilliant blue and triple blue from dark, and it's a heavy one. And then I don't need to do the ILM the through FAX or something like that. I inject the brilliant blue with BSS. What I do for inject anything in the eye, because I use valve trocar, what I do to inject inside the eye, I just close the infusion and I inject it with the closed infusion, because if you inject with the open infusion, sometimes you can have a jet stream and this stain can go, this dye can go underneath the retina. This is a problem, especially if this happen in the macular area. I think that will be a big problem. In this situation, I try to do, in the first case, I use the combing. It's try to close the hole, but even doing everything right, the macular hole was type 2 closed. It was not great because the border was not, the edge was not closed.
Okay. Thank you so much.
that was great.
Can I ask you? Yeah. Dear Professor Ferreira, thank you for the beautiful presentation, great surgery, great work. I would like to ask you about what is your approach in case with a primary failed vitrectomy and enough white peeling ILM. I saw you perform beautiful outer retinal transplantation, but maybe you have some another choice for additional steps.
You know, before, if I had done for recurrent macular hole, I think that it's very hard to do if you did the surgery, the first surgery, and you are sure that you remove the hyaloid, a good amount of ILM around the hole. I think that you have to go to two options, in my opinion. If you have access to amniotic membrane, it's a good option to use it. Or otherwise, I think that autologous transplantation is the best option for this recurrent what I will do is that. And in the second case, I use autologous transplantation because I could not do a very nice ILM peeling. And then I said, this is a very 50% of this hole don't close if you do everything right, as I did in the first case. And then I decided to go to the autologous transplantation because I didn't have access to amniotic membrane at that time.
Yeah, thank you. And I have one small comment about visualization. You're absolutely right. It's enough difficult, especially with choroidal atrophy, to clearly detect ILM. It's enough dangerous to remove it. But in my experience in such cases, I would like to use some contact lens that give us enough good depths of resolution and depths of field of. It's enough good decision. Some magnifying lens, contact lens.
I love that lens too. Most of the cases when I am doing ILM peeling, I use the Machmer lens, the high magnification lens to do that, the contact lens. The lens that we have used in the past, and we have used in the past. It's really nice to have a wonderful view for this wide field lens, like the Bion lens. It's not. I don't think that you have the same quality of view and the same depth of view in this with this lens. I love the lens, the contact lens too.
Okay.
Thank you, Doctor. That was a great discussion. I think we should move forward with the next
Magno,
talk.
let me just ask one question to Professor Magno. Magno, congratulations, great presentation. Please just tell me how you managed to use the fluorocarbon in peeling the ILM. Do you like using PFC?
Normally, if I have, first of all, I stain the macular hole, the region, the posterior pole. If I don't get, it's very difficult to manage the ILM peeling. I use if the retina is attached, I use the perfluorocarbon, and I like to have the first edge of the peeling before the inject perfluorocarbon, because I think that is easy. Because if you don't do that, it's very tough to get the first edge of the ILM to do the peeling. And in that situation, I rather use the without perfluorocarbon, especially in this case, this high myopic patient, because the retina detached, it's good for you to because the axial length decrease with the retina, the staphylogram, the retina is in the border of the staphylogram.
Thank you.
Yeah, thank you.
Thank you very much once again.
So
Thank
the
you,
next
sir.
talk would be moderated by Dr. Meenal. Dr. Meenal, are you there?
I'm going to stop the sharing here.
Hear me? Am I audible?
Yes.
Okay, so good evening, everyone. So the next talk is going to be by Dr. Andriy Rubin, who is an eminent VR surgeon from Ukraine. He's also the president of Ukrainian Vitreoretinal Society. He founded and headed the department of MIVS at the Academy of PD Education in Ukraine. And his talk is going to be on efficacy of lyophilized AMG for closure of posterior retinal holes in high myopic retinal detachments. Dr. Andriy, please.
Dear colleagues, I consider it a great honor and privilege for me to be able to address you here today. I'm sincerely grateful to Dr. Sethi for the invitation to take part in this really great conference. I have no financial interest for my presentation. Managing retinal detachment related to posterior retinal holes above whole retinal atrophy in high myopic and pathologic myopia represents a challenging vitreoretinal condition since standard laser retinopexy is ineffective. A variety of surgical techniques and approaches have been proposed and used to treat retinal detachment associated with posterior breaks in highly myopic eyes, including vitrectomy combined with an inverted or inserted internal limiting membrane, or anterior lens capsule technique, or autologous neurosensory retinal transplantation, or human amniotic membrane patching. We present a combination of two surgical techniques, lyophilized human amniotic membrane patch and tissue fragment insertion, ILM, posterior cortex on posterior lens capsule in two cases of retinal detachment with paravascular retinal breaks over pachychoroidal retinal atrophy in pathologic myopia. There are two types of commercial human amniotic membrane graft products now available for medical use. It's dehydrated and cryopreserved amniotic membranes. Lyophilized human amniotic membranes undergoes a freeze-drying process after cleaning, resulting in a dehydrated membrane that can be stored at room temperature and need rehydration before use. Alfie's case is a 67-year-old lady with nasal macula-on retinal detachment caused by full-thickness peripapillary retinal hole in highly myopic left eyes. Her axial length was 29.9. She also had lamellar macular hole and choroidal neovascularization with posterior pole staphyloma and choroidal retinal pigment epithelium atrophy. She had BCVA 0.04 decimal. We performed post-plant vitrectomy 25 gauge. Vitreous base was cutted and peripheral retina was checked for new tears. Posterior hyaloid was elevated and cutted until to equator and peeled from macula area. After that, air fluid exchange with replication of retina. Superior LM flap was prepared. And inserted into the hole and fixed with the Scott. After that, another fragments of posterior hyaloid was inserted into the hole. Flex loop was used to position at the both flat. Unfortunately, 2 weeks postoperatively retinal detachment occurred, and we must to remove posterior hyaloid as much peripherally as possible. Air fluid exchange, retinal reapplication. And we prepared and inserted human amniotic membrane graft. Graft was placed above the hole, and silicone oil was injected. We asked the patient to keep face down position for the first postoperative week. 1 day post-op, color and autofluorescent imaging showed well-positioned human amniotic membrane patch over the hole, and retina was reattached. OCT revealed the presence of homogeneous hyperreflective band with well-defined edges over the retina hole, and posterior hyaloid and island fragment into the hole with some residual fluid. 3 months post-op, fundus photo and autofluorescent image shows that retina was attached and human amniotic membrane is not clear visualized. No signs of inflammation or scarring. At 3 months, OCT reveals that human amniotic membrane in place, and there are no signs of subretinal fluid and retinal defect. OCT also reveals that anatomical improvement in the macula foveal area, with improving BCVA to 0.1. In 3 months, silicone oil was extracted, and 1 month after silicone oil extraction, we see that retina still attached, but partial elevating the human amniotic membrane patch age due to contractions occurred. Our second case is an 82-year-old man with also pathologic myopia, axial length 30.4. In 2019, he had full thickness macular hole with so-called laminar hole associated epiretinal proliferation, and sometimes we called it a yellow tissue on the edges of hole. Posterior pole staphyloma, whole retinal pigment epithelium atrophy, and BCVA was 0.05. Note that he also had enough severe atrophy in paravascular inferior air cuts. And the tear occur after 6 years. And in 2025, he suffered from macula of rhegmatogenous retinal detachment of the left eye with 2 retinal holes. It's a full thickness macula hole and posterior pole hole. BCVA was hand moving. We performed vitrectomy with posterior hyaloid removal and multi-layer inverted LM flap for full thickness macula hole and silicone oil. 1 month post-op, macula hole was closed, but unfortunately in the inferior part, we detect retinal detachment with enough big hole, about 800 microns. We decided to perform next vitrectomy under silicone oil without removal. First of all, we insert some fragment of posterior capsule. Aspirated subretinal fluid under silicone oil. And now maybe you can more clearly see a retinal hole. After that, posterior capsule fragment was inserted into the hole. Sometimes it's not so easy, and in such cases we use bimanual technique because of adherence to forceps some fragments. And also flex loop was very useful to check the correction position of fragments. We also prepared and implanted into the eye some human amniotic membrane. Membrane was deployed and repositioned above the hole. If enough mobile and easy moving under, above the retina. One week post-op, OCT reveals that human amniotic membrane visualized as a distinct hyperreflective layer well integrated with the retina. Also, we see some fragment posterior scapula into the hole. 1 month post-op showed that fundus imaging shows that well-positioned human amniotic membrane patch. And 1 month, we see that patch was in correct position with no evidence of subretinal fluid and no signs of retinal defect and BCVA 0.2 decimal and no also clear visible retinal defect. At conclusion, I would like to say that lyophilized human amniotic membrane patching combined with whole insertion of ILM, posterior hyaloid or posterior capsule fragments provides a safe and reliable method for closing posterior retinal hole associated with retinal pigment epithelium choroidal atrophy in high myopic retinal detachment. Thank you for your attention and welcome to peaceful Ukraine.
Thank you, Dr. Andrei. That was a really interesting talk. I'd just like to ask, how do you decide the sizing of the graft in such cases?
Why I use the graft in such cases? Because
no, the sizing of the graft. Sorry, sizing of the graft.
Sizing, yeah. Thank you. It's a very nice question because it's really individualized. We don't know exactly which the size is necessary, minimally necessary. The one is the possible complication during using such methods is dislocation human graft after the retina. That's why I'm afraid a little bit that possibly if patch will change his position, it's possible the operation will fail. That's why we now use maybe more bigger size than necessary really. Maybe the next step will be use more smaller or more accurate size. For example, as Stanislaw Ritsa used some cutaneous trypan, different size, 2 millimeters, 3 maybe, especially for each individual cases. But now we a little bit use more bigger size to protect dislocation.
And how do you avoid slippage in these cases? Like there were some studies where they pre-treated and the graft was put with assistance of LPCF. So what do you do to make sure that there's no slippage of the graft intraoperatively?
Yeah, it's also a brilliant question because, from my opinion, my experience not so big. It's few cases, but because as this membrane, this tissue is very thin, human amniotic membrane, lyophilized, it is not difficult to distinguish the basal and stromal pole, which is why in this technique we consider it's interchangeable for placement. I'm not sure correctly which sides of graft I placed to retina. You're absolutely right that now many publications, not so many, but there are publications with so-called pretreatment. It's using some ICG for dyeing membrane, and glucose also used for pretreatment. Maybe for this reason we also use some dyeing, but we use membrane blue. We hope that it can help us to fix more adhering to the retina. Yeah, it's really.
And what is your choice of tamponade in these cases?
In my opinion, for understanding what is really happened after operation of the first week, for example, we use silicone oil, especially when we have another different problem with pathologic myopia. And silicone oil allows us to give some visualization, especially in only one eye for such cases. And we see clearly what is happening with human amniotic membrane patch. I think that gas maybe due to more interface force can dislocate this graft. That's why maybe silicone oil is the first choice for my opinion.
Okay, thank you so much. Any speaker has anything to add? Any experience with the cryopreserved amniotic membrane? Because we usually use cryopreserved. Personally, I've not used lyophilized. Any of the speakers want to add something?
I think both cryopreserved and lyophilized preparation appear effective, but we use cryopreserved. I think it's more thicker graft, and maybe lyophilized easy to move on above the retina. But I haven't experienced with cryopreserved.
Cryopreserved is usually thinner, so we really have to stain, and the visualization is difficult, and handling is also difficult. So usually we use two instruments, usually a Tano scraper and a knitted-on loop to basically insert it and put it over the retina. So any comments from any other speakers or the panelists?
I have one comment.
Yes, sir.
I have actually. Have you ever used some viscoat or something like some Hilon to put over this amniotic membrane? I have done few cases of amniotic membrane, and we published a paper in our journal 2 years ago. We're using amniotic membrane. It was a multi-center study, and I think that to use something heavy like the Hilon, it's avoid this membrane to slippage from the place that you want the membrane to be. Have you ever used this?
It's a great idea. I have no experience with such method, but I will try. Thank you.
Yeah, I have done also in ILM peeling when I invert ILM peeling. After I do the invert ILM peeling, I put some Hilon over the flap, and this avoid the flap to move, and you don't need most of the times you don't need to use silicone oil, just use gas. It's enough for this situation.
Yeah. Thank you.
Thank you for your input. So my last question is, how do you decide whether you are going to put just amniotic membrane graft, or you will, take the combined approach and use a posterior capsule or ILM along with AMG?
Yeah. In literature, the biggest part of publication using only some technique, one technique, or subretinal graft, for example, as Italian school, Professor Stanislao Rizzo, or epiretinal, only a lot of publication. But for my opinion, using combined approach more effective. It should be more effective, as we propose, as we suggest, because some fragment, especially ILM, can introduce some gliosis inside the hole, as we clearly see in internal limited inverted flap. That's why it's reason for using to promote and to accelerate the gliosis inside the hole. We saw also interesting publication. It was some Mexican colleagues who published some paper. Garcia Vasquez published some paper using human amniotic membrane in rhegmatogenous traction retinal detachment in diabetic patients, and they use only epiretinal location and placement, and also detects that in 95% of cases, hole was closed, only with epiretinal. But for my opinion, it will be more effective when we use some adjuvant inside the hole.
Thank you, sir. That was a nice point. If anybody has something to add, otherwise we can move on to the next talk.
Yeah, thank you. It was a great discussion. I think we should
move on to
the
the
next
next
talk.
So I think Dr. Ashish Markan is our next moderator. So,
No, Dr. Minal, I would be introducing our next speaker is Dr. Taku Wakabayashi. He is from Japan. He is internationally recognized for his extensive work in advanced surgical technique in treating complex vitreoretinal diseases, and he has received many awards also, including the prestigious AAO Achievement Award and the ASRS Senior Honor Award. So please join me in giving a warm welcome to Dr. Taku, please.
All right, thank you very much. Can you hear me?
Yes, you are audible.
Yes. And the slide is okay as well? Okay, so thank you very much to the meeting organizers for the opportunity to present. So today I will be talking about vitrectomy with fovea-sparing ILM peeling without tamponade for myopic traction maculopathy. So as you all know, myopic traction maculopathy is a macular complication caused by traction highly myopic eyes. Vitrectomy is effective for maintaining vision and resolving schisis. Surgical techniques include 3-part pars plana vitrectomy. Any gauge can be used, but I prefer 27-gauge system. Removal of epiretinal membrane vitreous cortex using triamcinolone, ILM peeling, either standard or fovea sparing, peripheral vitreous shaving, and tamponade. But I don't usually use tamponade. I'll show you why. But as shown here, several variations exist in surgical techniques. According to the ASR's PATH Survey 2025, 33.5% of US and 57.2% of international surgeons perform fovea-sparing peeling, whereas 49.7% of US and 30.2% of international surgeons perform broad peeling. So the question is, which technique should we perform? So about the fovea-sparing peeling, this was first introduced by Drs. Hall and Shimada to prevent postoperative macular hole formation. In this technique, I always use triamcinolone first to visualize the vitreous cortex and epiretinal membrane and remove it from the fovea. Some adhere remove it and use G2 use vitreous removal. I as well stain with BBG and perform fovea sparing technique. In this technique, the ILM is peeled off in a circular fashion around the fovea, and the ILM at the fovea is left intact. You can see in the OCT image that the fovea is super thin, so you should not damage the fovea and complete the ILM peeling in a fovea sparing manner. And this is another case. I generally prefer 27 gauge because of the good wound sealing. Phaco vitrectomy for older patient. Phaco through clear corneal incision. And then after core vitrectomy, remove the epiretinal membrane as shown here. First around the fovea because it's strongly adhered to the fovea, so gently peeled off. And then use BBG to stain the ILM and do fovea sparing ILM peeling. And sometimes you can use cutter to trim the ILM and then remove the surrounding ILM. Then under chandelier illumination, shaving vitrectomy, and PCIOL insertion, and finish the surgery without tamponade. After surgery, you can see that the residual ILM at the fovea in the early postoperative period at 1 month, but it's no longer visible at 6 months and vision improved to 20/30. So we look at the outcomes of fovea sparing ILM peeling versus standard ILM peeling and found that the postoperative visual acuity did not differ significantly between the groups. However, fovea sparing tends to reduce the incidence of macular hole formation. You can see here 13% after standard ILM peeling versus 2% with fovea sparing ILM peeling. And as a result, fovea sparing technique may help prevent visual deterioration caused by postoperative macular hole formation. So I recommend performing fovea sparing technique to prevent macular hole formation in any types of MTM, including retinoschisis, lamellar macular hole, and foveal retinal detachment. And what about the tamponade? According to the PAT survey 2025, around 20% of the surgeons do not use tamponade, whereas over 60% of surgeons used gas tamponade. So the question is, which is better? So to answer this question, we created an international multi-center schisis study group, including 9 institutions from the United States, India, and Japan. Baseline characteristics are shown here. We had 136 eyes with tamponade versus 57 eyes without tamponade. Baseline parameters were comparable between the groups. Intravitreal tamponade included C3F8 gas in 14 eyes, SF6 gas in 57 eyes, and air in 65 eyes. Results are shown here. In both groups, the postoperative visual acuity significantly improved. However, interestingly, time for MTM resolution was significantly faster with tamponade. However, postoperative visual acuity and visual improvement was significantly better without tamponade. Postoperative macular hole formation did not differ significantly between the groups, indicating that regardless of the tamponade, macular hole may develop. So why do eyes with tamponades have worse visual outcomes? I do not have a clear answer for that, but postoperative retinal thickness was significantly preserved, and the proportion of intact ellipsoid zone was significantly greater without tamponade. Here's an example of the patient. This patient was treated without gas, and you can see that the gradual reconstruction of the outer retina and the relatively preserved retina at 18 months. This case was treated with tamponade, and you can see that just at 1.5 months after surgery, the schisis resolved, but the retina looks thin, likely because of the pressure of the tamponade. Here's another case that I treated without tamponade. At 1 month, you can see that ellipsoid zone is not visible. However, at 3 months, you can see that the ellipsoid zone is recovering, and at 6 months, ellipsoid zone is fully reconstructed at the fovea. So I think retina needs some time to recover itself, and if you use long-acting gas tamponade and overpressurize the retina does not have enough time to recover itself. We also found an interesting finding of schisis bending in the early postoperative period. This is superior, this is inferior. and tamponade have more effect on the superior retina, and you can see the bending, likely because of the tamponade. So my current idea is if the traction is adequately removed, the schisis may resolve itself without tamponade. So just let the retina to heal itself rather than active forceful resolution with tamponade. So to conclude, fovea-sparing island peeling is effective for preventing postoperative macular hole and associated visual deterioration. Schisis resolution is possible without tamponade. Vitrectomy without tamponade results in better visual improvement and preserved retinal anatomy despite a longer schisis resolution time. Thank you very much.
Thank you for such an insightful talk and wonderful surgeries. So I just want to ask regarding the fovea sparing ILM peeling. So what is your target diameter for the unpeeled foveal ILM remnant?
I
How
think
do you decide?
within one disc diameter. So
Wonderful.
I do not leave a large intact ILM because there is a risk of postoperative ERM formation, subsequent ERM formation on the remaining ILM because it serves as a scaffold for subsequent proliferation. So I usually do within one disc diameter and sometimes trim with cutter. But the port of the cutter should be away from the fovea to prevent flow to the fovea and prevent any iatrogenic damage to the fovea. We did the study looking at the postoperative ERM formation after fovea sparing island peeling and found that 17% of the eyes develop mild ERM after surgery at 12 months, but no eyes required subsequent ERM surgery. So I think those are usually mild, but if you leave a large ILM, there is a risk of more severe ERM in the long term. So I would recommend within one disc diameter.
And you mentioned about the no tamponade technique. So you leave the eye in saline only, or you prefer to do at least the fluid air exchange at the end, not putting the gas, but leaving
Just
the
in
air.
general, just in general, just fluid is fine. But if you're concerned about postoperative hypotony, especially in eyes like with axis length longer than like 30, 32 millimeters, then just put partial air, just 1/3, like 30%, for wound sealing without face down positioning, and then just finish. And then the patient can see from the post-operative day one, and they feel comfortable with that instead of, putting long-acting gas for a few weeks. But if you are concerned about like a tiny macular hole or you're not sure about that, then you can just put the full air, and I think that will be fine.
Okay, and if you find that there is already a macular hole with MTM, so you go ahead with fovea sparing only, or you do complete peeling in such macular holes?
Oh, if the macular hole is already developed, you mean?
Yes.
Oh,
Yes.
then you need, is that a postoperative macular hole or intraoperatively you found the macular hole?
Intraoperative.
Intraoperatively you found the macular hole, and then you definitely ILM flap or complete peel, depending on the hole size and the severity of the staphylomas. I do recommend multi-layer flap for myopic macular hole because there is fewer chance with standard ILM peeling.
And the last question that beyond the best corrected visual acuity you showed in your study, it is almost same with the fovea sparing and complete peeling both. But did you find any difference in microperimetry in foveal sensitivity or anything? Is
Oh,
it like better with fovea sparing?
we have not conducted a microperimetry, but I think as long as the macular hole doesn't develop postoperatively, even after standard island peeling, it's effective. the vision significantly improved. So, but there is a higher risk of postoperative macular hole, so that's why we need to perform fovea sparing. But I think there's overall there's no differences between the groups, but if you look at the cases, 10% of the cases of postoperative macular hole, those eyes likely develop visual deterioration of 3 lines or more. So that's why we need that technique to prevent that. You're asking so many good questions.
Thank you, thank you. Any other speaker would like to add something, please? Yes, Professor Magno, you can go ahead.
I would like to ask one question for Taku. Beautiful
Thank you.
surgery, but it's at least in my hand when I put crystal of triamcinolone, make me confused to do the ILM peeling. You know, it's sometimes you never know if you are getting some retina, some internal retina or something like that. I don't do ILM fovea spare ILM peeling, but what I think that I have done, I haven't seen some friends from Brazil. They put a small blab of perfluorocarbon over the macula, the fovea, just to know the limits, because you are very comfortable doing that, but sometimes you try to spare the fovea and over a sudden you remove the ILM without your wish. You know, it's sometimes it's not without your will. It's very tough to really spare in the fovea doing that. I think that put the perfluorocarbon, it's a good tip. I have never done, but I think that will be easier for me doing that, I think.
Yeah,
What do you
before
think?
I thought about that, before I really thought about that, but I didn't want to, touch or even, pressure the very thin fovea. Even I think a PFO it doesn't make iatrogenic macular hole, but it may have some, effect on the very thin fovea. So I don't like to even touch or put anything on the fovea in myopic traction maculopathy. But I thought about your idea, so I'm not sure if it really works or not. But yeah, that's a good idea.
Thank you.
Can I have a question? I don't know if you hear me.
We can hear you.
Yes, I can hear you.
Yeah, it's just it's a great presentation, but just one of the difficulties that I always face in cases of phagocytosis actually is to reach to the ILM to peel it. It is not always easy, and when even you reach the ILM, it is not always complete ILM. A lot of times in the myopic and phagocytosis, just pieces of ILM, and if you manage to move piece after piece, that's fine. But to have full control in ILM, it's not easy target all the time. Any tricks for this?
Yeah, especially there is an underlying chorioretinal atrophy. The ILM is super thin, and also it's sometimes, it's organized and it's fragmented. Because of the traction, there's ILM detachment also. So you need to make sure the overlying hyaloid vitreous cortex remnant removal and staying with triamcinolone and completely remove those to better visualize the ILM with BBG or ICG. Unless ILM is not well stained, if there is some amount of the vitreous cortex or ERM. So just remove it first and then stain. And then if it's not visible well, and then you can stain again and try to, understand well the status of the ILM. So you're right. It depends on the cases. Yeah. It's so difficult to visualize.
The other thing is, okay, sometimes even if we don't have these long instruments, and a lot of people just you cannot reach it, especially if there is staphyloma or something in myopic vision. And actually, I don't know. One of the things that I was thinking of, I didn't do it yet, but it's just in my mind. Okay, if I don't have to use trocar, can I go to 6 millimeter, for example, back from the limbus? And even if it's through the retina, so what? I'm just creating a hole. We can do laser later for it in the periphery as long as we are going to use gas anyway. Is it feasible thing to do?
Yeah, I think depending on the case, but there is a study from Dr. Kadosono from Japan looking at the distance of the pars plana from the limbus using anterior segment OCT, published in Retina. And if the patient have axial length longer than 30 millimeters, you can just insert from 5 millimeters. And there's another case. Paper from Dr. Ibama in Retina also that if the patient had over 32 millimeters, 6 millimeter insertion is fine.
So
And
it's
also there is
yeah.
a paper published from Dr. Baba in Retina recently that you can just indent and visualize the pars plana. The Dr. Hassan Mortada was also
yeah.
that about that just before inserting the trocar, just indent, lower the pressure, indent, and see the pars plana to see where you can safely approach. And then usually 6 millimeters is fine if the patient has over 31 millimeters. And also you can use the long shaft forceps.
We discussed this with Dr. Magno's talk, I think.
Oh yeah.
So yeah, we'll be moving to the next topic. We are running late
Okay,
of
thank
time.
you.
Yeah, thank you so much. I would like to invite Dr. For the next talk. Dr. Abhishek is there?
Yeah, I'm here.
Yeah.
Okay. So we have for the next talk we have Dr. Mary John Lai, and she is the president of Philippines Ophthalmic Society and also the assistant chair at St. Luke's Medical Center. A very long CV, and since we are running late, ma'am, why don't we go with your talk, ma'am?
Hello, good evening.
Good evening, ma'am.
Good evening. Okay, good evening, everyone. I'm happy to celebrate this year's World Sight Day by joining this webinar. I'm sharing my surgical tips for the management of myopic macular hole, a condition that can be challenging due to the structural changes in highly myopic eyes that were mentioned already by my colleagues in this session. So patient is a 63-year-old female. Her best corrected visual acuity was previously 20/25, which eventually decreased to 20/63 through the years. Her axial length was 29.8 as measured by IOL master, with a refraction of -16. Anterior segment findings were unremarkable except for mild nuclear sclerosis. On posterior segment examination, the disc is tilted with generalized thinning of the retina, especially at the area of the macula. Macular OCT showed full thickness macular hole with maculoschisis. So the surgical plan for this patient was 23 gauge pars plana vitrectomy, inverted ILM flap, and SF6 tamponade. So 23 gauge was preferred for this surgery because of its longer shaft, actually longer effective shaft. The 25 gauge has actually similar length, but it has a stiffening sleeve at the base, preventing us from inserting the entire length of the probe into the vitreous cavity. The Constellation vitrectomy machine, set at 10,000 cuts per minute, was used with the Zeiss Lumera 700 and ReSight viewing system. ILM peeling was performed under brilliant blue staining using the ocular Lander's Macular magnifying lens for better visualization, as mentioned also earlier. I'm more used to Alcon Gray Schaber 23 gauge ILM forceps for initiation and completion of ILM peeling. So this is the case. So the first tip is to choose the right instrument for the length of the eye. Choose the right stain. So I used brilliant blue to stain the ILM. While injecting, always check the perfusion of the optic nerve. So I removed the brilliant blue, shifted to Macumer contact lens for better visualization. I inspected the staining, but was not happy. So the fifth tip is it's okay to restain. This time I had a good staining of the ILM. So the ILM peeling, as we all know, in myopic eyes, it's quite tricky because the ILM tends to be thinner, more adherent, and more friable. So it's very common to have multiple multiple attempts to regrasp and reinitiate the peel. So maybe here, refrain from drinking coffee. So for myopic macular hole, I tend to enlarge my peeling. So consider larger area of ILM peel. This time I was doing air fluid exchange. So to keep the flap in place, for me, it's best to keep it really dry and position the flap over the hole. Temporal flaps are easier to reposition when aspirating the fluid from the nerve. And for highly myopic eyes, I suture to avoid post-operative hypotony. So at 2 weeks post-surgery, there was a reduction in the height of the schisis with a visible tissue bridging over the defect. The visual acuity was all nearly the same from pre-op. Serial macular OCT showed gradual resolution of the schisis and closure of the hole, accompanied by an improvement in vision from 2063 to 2030, 7 months post-surgery. So for my surgical tips, thorough pre-operative evaluation is very important, especially for highly myopic eyes. We need to be prepared with the right instruments for the axial length of the eye of our patients. Using a Landers or similar contact lens significantly improves depth perception and ILM visualization, which can be challenging in eyes with very thin retina. It is perfectly fine to restain the ILM if the initial staining is not sufficient or satisfactory. For myopic macular holes, consider a larger area of ILM peeling that can help relieve traction and possibly improve our closure rates. Suturing the ports in highly myopic eyes can prevent complications like post-operative hypotony. And finally, closure may take longer in myopic macular holes compared to idiopathic holes. So setting a realistic expectation with our patients is very important. Thank you so much for your attention and hope to see you in Manila this December for APVRS. Thank you.
Thank you, ma'am. Great talks. Ma'am, do you do inverted ILM flap? Would you prefer inverted ILM flap in these cases? Or which type of flap technique do you prefer in these cases?
Yes, I prefer inverted ILM flap. So sometimes I tend to make multiple flaps. No, others they just do a temporal flap and then put it over the hole. So sometimes I tend to create more flaps for these cases.
Right. Anybody has any other questions or any comments?
I have maybe comments or question. In literature now, we observe some result that after surgery, for example, macular hole retinal detachment in high myopic eyes, best corrected visual acuity or function result increase, for example, in 1 year after surgery, but then decrease for some atrophic changes, retinal or choroidal. And for me, it's very, very interesting and maybe not so clear. I would like to ask maybe our colleagues, is it really dangerous that all of us seen his practice, or it's maybe more theoretically?
Maybe sometimes it's hard to say if it's from the surgery or it's the natural course of the eye, especially in highly myopic eyes, because well, from the start, the retina, it's not so healthy. Okay, so I'm not sure with others.
I have the same feeling, it's, are you hearing me?
Yes, yes, clear.
Yes.
In diabetic, it's usually to see that kind of situation. You do the ILM peeling, and then you don't know if the ILM peeling is responsible for the atrophy that can come, or if it's the natural disease. We see a lot of patients with macular edema, and then all of a sudden he gets atrophy of the macula, something like that. The natural history maybe is more responsible for that than really the ILM. Even though theoretically the ILM can do that because we remove the Miller cells, and then you can have this atrophy.
Thank you. Dr. Taku, do you have any comments on this?
Oh yeah, I think there's a few papers published in Retina showing that vitrectomy may accelerate the macular atrophy in highly myopic eyes. And we did a study looking at the progression of macular atrophy after myopic traction maculopathy surgery. And the two major risk factors were postoperative macular hole retinal detachment, and choroidal neovascularization. So I think and the highest risk is macular hole retinal detachment. So I think to prevent macular hole and macular hole retinal detachment in MTM surgery is important, and also surgery before macular hole develops is also important to prevent further progression of macular atrophy after vitrectomy.
Arigato.
So what is your tolerance for MTMs? Like, what is your best corrected visual acuity? Because many of times they will come with very good visual acuity, like 6.9, 6.
Oh yeah, so indication of surgery, you mean?
Yeah.
I think it depends on the preoperative.
No, with very good visual acuity, like 6.9, will you operate? Do you document the?
So like 6.9 means 20/30. So that's I think a indication for surgery if the patient has foveal retinal detachment. But we also did a study published in Graphe this year that if you go do surgery at the time of like 2020 and 2025 vision, there is around 16% chance of visual deterioration of 3 lines or more because of the postoperative macular formation. And then those patients will never be happy. So I think we should not rush into the OR if the patient has good vision, but I do consider surgery if the patient is 6.9, that's 20/30 in the US, or in Japan 0.6 or 7 or worse. But if you wait too much until 2200 or so, then there's a less chance of having good vision, right? So I think it depends on the case and patient characteristics, subjective symptoms, and also preoperative retinal morphology also are important to consider surgery. We should consider the risk-benefit ratio all the time because it's not completely safe surgery.
Taku, sorry, may I ask a question? So, if you have a patient with increasing height of the schisis but no detachment yet, with good vision, will you advise? Not yet.
No, just regular follow-up 2 to 3 months. It's surprising that even with a very severe schisis, patient have 20/20 vision. And I sometimes do a microperimetry and there's no reduction in retinal sensitivity, but it's surprising. But that's not, the retina is not damaged yet, but retina will be damaged thereafter, after the long term. So that's the timing of surgery. Once the patient notice the decrease in vision or metamorphopsia, then there is a good reason to, perform surgery. But I do not recommend surgery like severe MTM, but have still good vision.
Yeah.
Have
Same
you
here. Thank you.
have you ever experienced a case of myopic fovea waxing and waning pattern without, I mean, it is increasing in
Worsening, yeah, same height, but becoming worse and worse. I think because of the cumulative damage to the retina. The height is similar, but still the vision becomes gradually decreased. So that's also the reason to consider surgery. I have many cases, but I didn't have enough time to show this time, but yeah. So regular follow-up is very important.
So 3 months, I think we all agree on that.
Yeah, depending on the case, if the patient has foveal retinal detachment, then I will follow in 1 month.
Yes.
If it's very mild and stable, maybe 6 months is fine.
Right.
Thank you, everyone.
Thank
Thank you, all the speakers and all the panelists to join this. I think the next session, people are waiting. So I think Dr. Anujit is there. So you
Yes,
can
ma'am.
go to the next session. Thank you. Thank you, everyone.
Thank you. Great session.
Thank you.
Thank you, everybody.
Thank
Thank you, all presenters.
Thank you, everyone. So we will begin the next session. This is session 3 in Hall D, and the title of this session, it has 4 speakers, and it's called Case Files from the Edge, Unraveling Surgical Enigmas. And the first speaker for this evening is Dr. Hassan Farhat. Dr. Hassan, sir, if you are there, if you can please
Yes,
share your
hello.
screen.
Hello.
Yes, good evening.
Good evening. Do you hear me?
Yes, we can hear you.
Okay, I can share my presentation, yeah?
Yes, you may share it.
Okay, it's good now? Yeah?
It's visible. If you can just go to full screen.
Okay.
Yeah, we are good to go.
Yes, it's good. Yeah, it's best regards from Kiev. I'm very happy to see you, to be with you. And thank you so much for invitations. In my presentation, I want to share with you my experience and my own conclusions about macular surgery of MACTEL type 2. The term of macular telangiectasia has been used by Dr. Donald Gass in 1968 as a different entity from Coats disease to describe dilated retinal arterioles, capillaries, and venules, and other abnormalities such aneurysmal dilatation, vascular leakage, and exudation. Today we know that the MACTEL is the result of Muller cell degeneration. As we know, the Muller cell provide energy and nutrient to the neurons and protect them. The degeneration of Muller cells leads to nutritional deprivation of photoreceptors and retinal pigment epithelium metaplasia and development of exudative neovascularization on the most severe stage. The MACTEL is divided into 3 main types. Type 1 usually affects one eye. It's often observed in young people and is thought to be similar or possibly a variant of Coats disease. Type 2, idiopathic, the most common of the 3 types, usually affects both eyes and is often observed in older people, mostly women with diabetes and genetic predisposition. Dr. Lawrence Janussi divides the types to aneurysmal, it's similar to type 1, and perifoveal is similar to type 2. The MACTEL research group, using multimodal imaging, develops a classification of macular telangiectasia according to the severity of the disease and divides it into 7 grades. The grades 0 till 3 shows the presence or absence of central or non-central ellipsoid zones break. The grade 4 shows the presence of OCT hyperreflectivity. The grade 5, presence of pigmentary changes, and the grade 6, the development of exudative neovascularization. Sometimes MACTEL diagnosis challenge us because it's easily overlooked and overlapping other retinal vascular disease. But now the multimodal imaging serves to make the challenge and the diagnosis easier and easier. The OCT often serves as the first diagnostic imaging modality for suspected MACTEL cases, and usually we find the following sign of MACTEL. The first of all, the hyperreflective cavities. The retinal outer layer disorders, ELM, especially ellipsoid zone. The ILM drapery is very characteristic for the MACTEL type 2. ILM drap over the affected areas. We see the formation of lamellar or macular holes and formation of neovascularization and neovascular membrane. The autofluorescence can detect very early the first signs of pathology, like the increase of temporal peripheral autofluorescence and the pathognomonic loss of normal foveolar hypoautofluorescence caused by the depletion of the luteal pigment. The OCT angiography may help us to detect the abnormal temporal retinal vessels, reduced capillary network density, capillary dilatation, deformation of foveolar avascular zones, abnormal anastomosis, and in the last stage, the neovascularization and neovascular membrane with exudative. On the fundus photo, we can detect increased retinal transparency in the foveal region. A. The rectangular vessels, we can find the RPE with hyperplasia and crystalline deposits. Now I will show some case about macular surgery for MACTEL. The first case is a woman 65 years old with extra large macular hole with diameter 616 micron on the left eye. The visual acuity before surgery was 0.1. I performed ILM peeling with temporal flap. We see some difficulty with visualization of the ILM due to the changes of the RPE. So I stained the ILM more than once. For staining, I used a membrane dual blue. Anyway, it was not very easy to peel it. I finished the operation with 20% SF6 tamponade. We see that the hole is closed. The visual acuity during the first months after surgery was stable. And after 6 months, we see a recurrent macular hole with decreasing of visual acuity. The second case is also a woman with macular hole on the left eye and visual acuity 0.2. we see typically for the mactal changes on the retina with hyperreflective cavity and ILM trapping. Here I performed a wide ILM peeling. I decided to make peeling without flap, considering the small diameter on the hole of the hole, but we see there is a difference between the hole onicity and during the surgery. Also, I finished the surgery with 20% SF6 tamponade. And also we see the macula is closed during the first 2 weeks, and after 1 month, we observe a full thickness hole. And after 6 months, we see a macular hole with retinal proliferations, typical for inverted flap surgery. The third case is for a woman with lamellar hole on the left eye. The visual acuity was 0.3. We see also typical change for mactel. I performed also ILM peeling with SF6 gas tamponade. All surgery was 25 gauge, and usually I recommend face down position for less than 24 hours under control of OCT. After surgery, we have excellent anatomical and functional results with visual acuity 0.7. After 6 months, we see a break in ellipsoid zone. Here are some conclusions about the efficiency of mactel surgery. First of all, is unstable anatomical results, lower than average closure rates, lower than average postoperative visual acuity, and functional and anatomical results of the surgery are better at the beginning stage of the disease before the appearance of macular hole. I believe that the first choice surgery for the macular holes is the inverted flap in this case. Due to the lack efficiency of surgical treatment of mactel, a great hope is placed on cell therapy like anti-501. The anti-501 or Incelto in March 2025 received its first approval for the treatment of mactel 2. It's an implant that contains genetically modified RPE cells that produce ciliary neurotrophic factor, the protein that provides neuroprotection to photoreceptors. The Incelto is inserted or implanted into the vitreous and sutured to the sclera. And we observe a significant increase of preservation of photoreceptors and ellipsoid zone. For neovascular cases, intravitreal anti-VEGF injection, I think, is still the mainstay of treatment. Thank you for your attention.
Thank you so much, Dr. Hassan. I think that was an excellent overview with some excellent surgical cases in this in mactel. Do we have any questions for Dr. Hassan?
I have one question. Do
Yes.
you think if you were using the Incelto, the results would be different?
I don't use Incelto, and
I know, but it's new technology. You hope that could be different.
yes, I hope that will be different because I think that the main thing for us is to fix the problem at the beginning. We observed that on the late stage, when the macular hole is formed, the efficiency of the surgery is absolutely not very good. And so we hope to stop the disease in the beginning stage.
Yeah, but you see, the point is that the problem of MACTEL, it seems to be exactly on Miller cells. And when we do remove the internal limiting membrane, we are causing additional damage to the Miller cells. So
yes, maybe this is the reason of
maybe it's just the case of removing the epiretinal membranes and not touching the internal limiting membrane. I've been watching the last section, and we have been noticing in many cases that we remove internal limiting membrane after time, after many months, after many years even, all the retina, the internal retina, it just get thin and thinner with time. Of course, we don't see much change in vision. Hopefully, it's going to be stable for many years. But we see there is some anatomical thinning. We all haven't seen that. And maybe just removing the epiretinal membrane and not touching in these cases of MACTEL would be with Anselto a better approach in this case. But congratulations for your efforts. It makes us think a lot.
Thank you.
Thank you so much. So in the interest of time, we'll move on to the next speaker. Can I invite the next moderator, Dr. Shanili Otola?
Thank you, Dr. Anujit. So our next speaker is Dr. Andre Juca, who's a distinguished retina surgeon from Ceará, Brazil. Dr. Juca is a professor of ophthalmology at the Federal University of Ceará and a director at the CLDO and CC. He also serves as a preceptor for the Vitreous Retina Fellows at ICO. So I'm sure with his vast clinical and surgical expertise, he'll bring great insight to today's session on the complex cases of PVR and especially macular PVR. On to you, sir.
Thank you very much. We are all familiar with the importance of tractions in developing anterior posterior traction and tangential tractions in developing macular holes. But we have this case that make us think a little bit different because this was a retinal detachment case. This was a primary. We did a phaco-vitrectomy. First, we did a phacoemulsification, and then we were removing all the vitreous. And this was a long-standing retinal detachment. Maybe months the patient didn't notice that he was losing vision for some time, and then he came to get this retinal detachment surgery. And we saw there was something in the posterior pole, but we keep doing the surgery, and we found out this tear. And we look at it and said maybe this is a subretinal membrane, but maybe it's not mature. Maybe it's going to be okay if we just do the laser and gas, and vision is going to be okay. This was there was some small and other big tears, and we decided to treat all the retina anyway with laser, 306-degree laser, because There's many ruptures that occurred. And there was this, as you can see, there is this membrane, supraretinal membrane, that we thought maybe is not going to affect the macula. But since the gas was coming out, we realized there was a macular hole. The patient didn't have a macular hole. And we see that the membrane is just very close to the edge of the macular hole. We removed the epiretinal membrane, but as you can see, there was no we removed the internal limited membrane, but there was no epiretinal membrane. So there was just the internal limited membrane, and we were not sure that this was enough because there was nothing. But then we decided to remove this supraretinal membrane. As you can see, this supraretinal membrane was thick and was passing just on the side of the macular hole. And we thought that maybe this was the cause of the macular hole, the supraretinal membrane causing a macular hole after a retinal surgery. So remove, of course, we've also and you can see that the macular hole is closed. So this was very atypical for us because it showed that not only epiretinal membranes and tangential tractors, but even supraretinal membranes can contribute, at least in some cases, to cause macular holes. And thank you very much for the invitation. It's a great time to be talking together about these very unusual cases that and difficult situations that we now and then face in this a special day for all of us. Thank you very much. You are muted. I can hear you.
Yes, sorry. Thank you, Dr. Juka. I did have a question for you, sir. I'm sorry if I missed the fact that was this the primary vitrectomy for the detachment when you noticed the subretinal membrane?
Yes, there was already, it was not very clear, but it seemed that was already something. But of course, with some weeks, the supraretinal membrane developed and it became more mature. During the first surgery, it seems right away there was something under the retina. But sometimes we can leave supraretinal membrane and it does not bother the result. But this one was close to the macula. It was right in the border of macular area. So if the supraretinal membrane is just on the fovea, fovea is very, that's why we have a macular hole. It may also contract and contribute to the macular hole formation.
Right. So you would recommend that doing surgery for a detachment with PVR with the subretinal membrane at the macula, maybe in the primary setting we could address it, or what would be your experience, sir? Because
well, of course, now I would have done the removal of the supraretinal membrane in the first surgery. Of course, that at that time was not sure that is going to mature and was not even though sure that it was going to cause a macular problem, even a macular hole, was not, I didn't thought that at the time of the first surgery. But of course, that when we went to the second surgery to close the macular hole, then we realized that it was the supraretinal membrane that was causing it because there was no epiretinal membrane.
right. Thank you. Yes,
I just want to add, I think it's a very unusual complication, especially we saw in the surgery that even with the SRG, the retina had settled quite nicely. And usually, like so many times with scleral buckle and even in vitrectomy for SRGs which do not cause any traction, we get away with them. But this was an unusual case, and I think it's something to do with the damage that the surgery itself inflicts on the Mueller cells, which along with this SRG contributes to a macular hole forming. Nice case, sir.
Yes, Yes, there is some cases that don't have supraretinal membrane, and even after some time they do develop macular hole. They are unusual cases, and maybe there is, in this case, there is epiretinal contraction, but this one was under the retina.
One last question, Dr. Juka. So, like you said, in some cases, they do develop macular pucker or epiretinal membranes and secondary macular holes. So, for the primary vitrectomy, again, for RD with PVR, would you recommend an obligatory ILM peeling, or would you?
Yeah, that's a very good question. I recall a patient that was a friend of mine that I decided to do an IMM peeling, and during the first repair to avoid the secondary complication. This was many years ago. I don't recommend that anymore because most of the patients are not going to develop epiretinal membranes or macular holes. So, and the internal limited membrane, it has a function. We are removing it and causing damage. We are always balancing damage and, an advantage of each situation, that each thing that you do inside the eye. So I think we should not remove epiretinal membrane because this can cause damage, like retinal thinning with time. And if you don't need to, if it's not broken, you do not fix it.
Right. Thank you, Dr. Juka. In interest of time, should we move on? Are there any other questions from the panelists? Otherwise,
Do you mind I excuse my colleague, Dr. Muhammad, if I can do my talk before him, because I have to go, unfortunately, if you don't mind. I'm Dr. Ibrahim, the last talk. And he kindly agreed on the chat, and he doesn't mind.
sure, sir.
Sure. So I would like to take the opportunity to introduce Dr. Ibrahim El Grabli, who is the consultant physician at Cleveland Clinic in Abu Dhabi. And he's going to share with us some interesting cases about double peelings. Over to you, sir.
Okay. Trying to open this. Okay. Send to Zoom. Okay. Sorry, I thought, yeah, it's opening. Can you see my slides now?
Not yet.
What I don't know what to do. This is your screen shared. I think it says.
It's saying that you've started screen sharing, but we still can't see.
So you have to enter the full screen mode.
Yeah.
Hello, can you see the slides or not?
No, sir, I select screen to enter mode.
Get out from I see it, but I don't know why I came out from the Zoom. Just let me see what's happening. I don't know. Okay, so should I say share? That's what I'm doing, and that is the one.
Yes, yes. Now we can see it. You
can
can
see
give,
it.
yeah. You can go to the slideshow, sir.
I can guess message. Okay, great. Sorry for this slideshow. Yeah. Okay. Can you see it?
We can see the full PowerPoint window. Yeah, now we can see it.
Okay, that's fine. So actually, the double bill is always a question, and as Dr. Joka said in his talk, okay, I'll not do the ILMB in cases where he had even subretinal convergence. So when to consider removing the ILM with epiretinal membranes? Actually, when you see a case like this, and with restriction retinal attachment and thick membranes like this, you just carry on cutting, removing. And I don't know if after what I mean, taking care of everything and just removing the membranes, will you leave ILM in a case like this? Especially with the high tendency of fibrous tissue reformation and traction retinal attachment. And actually, okay, you can carry on staining and just to be sure there is no further vitreous or whatever. And when you stain, I think in cases like this, ILM should be removed, and that's what a lot of people prefer in cases of traction retinal detachment. Another case, again, when you go for a case like this, traction retinal detachment here, and as you can see, just it's very tough and thick membrane, and after taking all the vitreous and just taking all this membrane, there is very tough membrane here. Are you expecting after removing an epiretinal membrane like this, the ILM will be intact? Or it is a question that should we remove it or not remove it? As long as you can clear the fovea as much as you can, definitely this is one of your main targets. And in cases like this, just while we are doing the surgery, I just prefer here to use just, especially if it's over the macula, the membranes over the macula directly, you are trying to avoid any creating any tear here, and definitely it's a bimanual technique and using the scissors. Usually that's what I prefer rather than keep making a traction on the fovea and creating holes in these cases. And you can go with a nice surgery again. One of the problems that you face in cases like this, and second day after the surgery, you can see this hemorrhage over the macula, especially after you put your silicone oil. And the silicone oil with the periretinal hemorrhage are bad combination. It's usually can lead to fibrous tissue formation and traction attachment again, and even permanent loss of vision in these cases. And one of the tricks that I learned, and it worked beautifully with me, actually, in a case like this, I used TPA, intravitreal injection of 25 microgram per 0.1 millimeter alteplase. I do it in the clinic. Second day, if I see something like this, I usually go inject it intravitreal. The pharmacy just to prepare it and it come nicely, and then I do paracentesis because I'm injecting 0.1 ml. I don't want the pressure to be high. Check the pressure after, and let the patient lie flat for nearly 45 minutes because the oil will be up and the drug will come down directly over the fovea. And as you can see, after 2 days, this is a nice trick. That's what happens. And this patient, 3 months after the injection, and she achieved beautiful 20/40 vision later on. Again, epiretinal membranes in a case like this, when you see 17 years old female patient, she's not diabetic or anything, and just she's coming, all what she had premature, she born premature. And even I don't know how long did she have this condition, but massive epiretinal membranes there. Definitely, I'm thinking about case here. It is diagnosis of combined hamartoma of retinal and retinal pigment epithelium. And in these cases, we'll find layers of epiretinal membrane and even intraretinal membranes and even subretinal membranes. One of the things that you need to do here, very, very careful with removing epiretinal membranes, because sometimes they can be connected to the intraretinal membranes and you can create easily while you are peeling a big macular tear or hole here. And again, I think just removing the ILM in these cases is mandatory, because I think it is a scaffold which will definitely lead to reformation of epiretinal membrane or recurrence of epiretinal membrane again. And as you can see, these are layers of thing. And when you stain, you can find still evidence of ILM, and that you need to clean just to make everything clean in this area. So this is how the case looked later, and it's much better than we started anyway. So the epiretinal membrane in tractional retinal detachment, definitely there is evidence that there is 30 to 50% of these cases. What I mean, diabetic vitrectomy has been it's been published that 30-50% tendency to recur in traction retinal detachment. And also data suggests that ILM peeling during primary traction is safe, regardless whether the macula is attached or there is detachment in the macular area. And epiretinal membrane formation and retinal elasticity, will help resolution even in persistent submacular fluid. IM peeling is indicated in this case, especially because, as I said, you are not worried about anything. They always claim that the removing ILM will damage the macroglia and the blades or whatever. And however, in these cases, the macroglia is not an issue because the damage has already occurred in cases like what I show, and even the molar cell and the blade has been damaged during these cases. The other thing, even if you are talking about idiopathic epiretinal membrane, the main reason for removing ILM is preventing the recurrence. And in meta-analysis and big review of literature, the 75% of the studies revealed no statistically significant difference in visual acuity between either removing the ILM or leaving the ILM after removing the epiretinal membrane. So if there is no difference in vision in most of these cases, so why you are worried to remove the ILM? On the other hand, you can argue, okay, why you are removing the ILM? We are removing the ILM because definitely there was a much decrease in the incidence of recurrence of epiretinal membrane after removing the ILM in idiopathic epiretinal membrane. So, and my conclusion is, if you have traction retinal detachment, if you have cases like the combined hamartoma that I show, in a lot of cases where there is PVR and all these kind of things, the blood retinal barrier is already broken. And definitely the tendency of formation of membranes and epiretinal membranes again would be higher. And in this case, it's better to remove the ILM in order to prevent the recurrence. Even in the idiopathic epiretinal membrane, there is no consensus because they said the vision will not be affected that much, and at the same time, the recurrence rate will be much lower. In conclusion, ILM peeling could significantly reduce recurrence rate, but not significantly improve the recovery of the visual outcome or decrease the thickness of central macula. Thank you very much.
Thank you, Dr. Ibrahim. That was a really nice collection of cases. And since the previous talk, Dr. Juka said that, I won't go chasing ILM in a primary RD, and you kind of counteracted with all of these complicated cases. So just one query, like you said, all these pathologies, they usually also involve the ILM, and they necessitate ILM removal. But what would be the extent of your ILM peel with respect to different pathologies?
Exactly. For traction retinal detachment, as you can see, usually we have massive membranes covering most of the macular area, even the vasculars either. In this case, as much can. I reach to that case, just trying to be sure that the macula is at least clear, if I can. In most of the cases, the retinal membrane that much of ILM, because most of it, sometimes it comes with the epiretinal membrane, a lot of it, and all what you need a little bit of clean here. But if the ILM is still intact, in many other cases, you will see the corrugation, you will see the folding, which is catching your macula as well. And in these cases, it's very obvious that you need to remove this. You cannot leave it. And but if you have intact ILM after removing the epiretinal membrane, I take it to the arcade.
Okay. Any other questions from the panel or any other speakers? Okay. I would request the next. Thank you, Dr. Ibrahim. I would request.
Thanks for the invitation as well, and thanks to my colleagues. Unfortunately, I had to go because maybe we started a little bit late. But thank you very, very much for this nice opportunity, and to see all of you.
Sure, sir. I would like to request Dr. Gaurang to introduce the next speaker.
Yeah, hi. Thank you, Kaustubh. So next we have Dr. Mohammad Awadallah. He will be speaking on vitrectomy in asteroid hallosis, not an easy task. Dr. Awadallah is currently a professor of ophthalmology and a very senior vitreoretina surgeon in Department of Ophthalmology, Faculty of Medicine, Cairo University, Egypt. He has also numerous publications. So over to you, sir.
Thank you, Team Pan Ophthalmologica, for this kind invitation, Dr. Vaiba. And I'm going to share my screen here, hopefully. Yeah. Can you see now the
Yes,
presentation?
yes, we can see it. Yeah, we can see it. You will have to go to the PowerPoint window. Yeah, perfect.
Okay. Okay, great. So I will draw some attention to not so common disease in during vitrectomy, which is asteroid hyalosis and vitrectomy that sometimes some surgeons find or think it is an easy task, but again I will show you why it is not. There is no financial disclosure. First, what is asteroid hyalosis? Asteroid hyalosis simply is calcium lipid complexes filling the vitreous cavity. Actually, asteroid hyalosis rarely causes visual disturbances, and hence the indication of vitrectomy for asteroid hyalosis per se is rare. So when it is indicated for pars plana vitrectomy, it is usually when it is very dense, as we can see here in the photo on the right, is very dense, then in absence of any other pathology, and you think it is or it contributes to the diminution of vision, then you have to do vitrectomy. Or more commonly, it is associated with a second pathology that by itself is an indication for vitrectomy, such as PDR, which is this is the second scenario is the most common. Why vitrectomy in asteroid hyalosis is different than in other cases? Because of the nature of the vitreous in asteroid hyalosis. First, there is much lower vitreous liquefaction prevalence in such cases, and much lower prevalence of posterior vitreous detachment. And as we can see here in this B scan, sometimes there is a characteristic lucid interval between the highly echogenic deposits of asteroid hyalosis in the vitreous cavity and the retina. And many think that this is a total PVD, while it is not. Usually, the incidence of PVD in such cases is low. There is a strong anomalous vitreoretinal adhesions in such cases, and vitreous cases is very common. So, as we all know that peeling of the posterior hyaloid is considered a crucial step in all pars plana vitrectomy. But when it comes to cases with asteroid hyalosis, because of the aforementioned reasons, this might represent a real surgical challenge in asteroid hyalosis. I will show here a couple of cases that demonstrate this argument. The first case is 60-year-old gentleman who complains of diminution of vision in his left eye. Best corrected visual acuity is 0.2. There is no diabetes. Is B scan and examination shows very dense asteroid hyalosis that even obscures visualization of the posterior segment. And actually, this is also an indication to remove the posterior hyaloid, because in many diseases you have to follow up on something in the retina that you cannot see with through asteroid hyalosis. And as we can see here, a report with B scan that comes as a total PVD, and it just represents lucid interval characteristic between the asteroid hyalosis and the retina, and it is by no means a PVD. So the patient was booked for vitrectomy, as we can see here. I starting with cord vitrectomy, thinking it is an easy case, walk in the park, eating all steroid hyalosis I see in my place. Then I went for the crucial step, which is the posterior vitreous detachment. Then I tried after staining with a triamcinolone, I tried hardly to grab or aspirate or detach the posterior hyaloid. I couldn't for a long period of time. Then I succeeded to open a hole with a tiny scraper in this strongly attached hyaloid, posterior hyaloid, elevating with the hyaloid with some force, and with the occlutome, as we can see here, this is propagating a wave of the posterior vitreous detachment, and I succeeded finally in removing this hyaloid. However, on completing vitrectomy, while moving to the periphery to complete the vitrectomy, I was surprised that there are breaks and holes adjacent to the vitreous base. And those are multiple breaks, not concentrated at one segment, but it involves a very large area. This is obviously because of the undue traction on the strongly attached posterior hyaloid that converted just a simple vitrectomy into a complicated one, ends up with endolaser and gas tamponade. And here comes the question, was peeling of the posterior hyaloid is justified in such case, or it's just a management that went so far? This is another case of a secondary pathology that necessitated kind of pars plana vitrectomy, but it was associated with a steroid hyalosis. She is a 55-year-old lady with uncontrolled diabetes. Best corrected visual acuity in this eye is 0.1. Posterior segment shows PDR with dense steroid hyalosis, preventing adequate PRP and subhyaloid hemorrhage. There was some hazy view, but the OCT showed the tractional diabetic macular edema. So it's obviously an indication for vitrectomy for many reasons. So the patient was booked for vitrectomy, and we'll see here this is the start. Before starting, as you can see, the posterior hyalosis moves with the parallax here against movement and starts vitrectomy. Again, the same nature of the vitreous is strongly attached to the posterior hyaloid, makes it quite difficult to remove or to detach. And as we can see here, the blood under the blood under the taut hyaloid is diffused with diffuse bleeding point that is those bleeding points are multiple, so many, and they are flat with the surface, very difficult to detect even by the rising pressure, doing endo laser at some of those points. I suspect that the taut hyaloid was keeping those focal points in check, and when you grab and you strongly detach the hyaloid, you end up with excessive bleeding. So pars plana vitrectomy may be indicated for a steroid hyalosis, rarely as a primary cause of diminution of vision, and more commonly for another pathology. We have to understand that the nature of the vitreous and vitreoretinal attachments are quite different in a steroid hyalosis. Therefore, one has to be cautious in peeling the posterior hyaloid in a steroid hyalosis, and it can be attended with complications. It is not an easy task, and one may consider not to peel altogether the posterior hyalosis in some of the primary cases. And thank you very much.
So, Dr. Mohammad Awadala, it was a very nice presentation. You have, sir, very briefly summarized a very rare, I would say, our OTs don't have common the asteroid hyalosis cases. Just a couple of questions, sir. My first question would be the PDR case with AH. Did you give any like pre-op anti-VEGF to just reduce the bleeding? As you just said, it becomes difficult.
Actually, I do not give anti-VEGF for all cases of PDR to start with. And I thought there was a vitreous hemorrhage, and I don't like to give anti-VEGF for something I not see. So if you have like dense vitreous hemorrhage, I do not give blind anti-VEGF. The third thing, I thought it is not that difficult vitrectomy. There is no much membranes, much traction, but I was surprised by the quality or the nature of the posterior hyaloid that's strongly attached all through. And I personally think it was checking the disease underneath. So basically you have a process, the PDR, it should penetrate through the vitreous. And because of this very strong attachment is keeping everything in check. Whenever you remove this cap of the vitreous over the disease, then you get this diffuse bleeding from all over the place, from very small points, and you try to treat those points so not to get post-operative hemorrhage. So I just wanted to draw an attention to some difficulty you might face if you see steroid hyalosis associated with a secondary pathology.
I think very well highlighted, sir, and very the tips you have given would be surely useful in our surgical practice day to day. Thank you so much for your time. So, in the interest of time, I think we would like to hand over the next session to Dr. Anjana Mirichkar. Is she here?
Yes, I'm there.
Okay, so I'd like to thank every speaker who was there for the session, and thank you so much for giving your time. And have a nice day ahead.
Thank you very much.
Thank you so much.
Good
Thank you so
evening,
much.
dear seniors and respected seniors and dear colleagues. We would be going ahead with this next session, that is Retina-Awesome session, complex cases decoded. Before that, I would like to thank Dr. Vaibhav Sethi and team Ophthalmologica. So our first session is, I would like to introduce Dr. Professor Wai-Ching Lam. He is the head and medical director of ophthalmology, Department Vancouver General Hospital and University of British Columbia Hospital and clinical professor of University of British Columbia. Between 2016 and 22, he was the Albert Bing-Ching Young Professor of Ophthalmology, University of Hong Kong, Chief of Service, Department of Ophthalmology, Queen Mary Hospital and University of Hong Kong Hospital. Between 1996 to 2016, he has taken various education leadership roles in University of Toronto, a residency program director for 2001 to 13, vice chair of education from 13 to 16, continuing education director from 1996 to 16, and Vitreoretina fellowship director from 2002 to 2016. He is a committed medical educator and has won 16 teaching awards. So Dr. Lam is a vitreoretinal surgeon with clinical interest in adult and pediatric retinal diseases. He received the Senior Achievement Award from APAO and Achievement Award from AAO and Fellow and Senior Honor Award from the American Society of Retinal Specialists. So he has published over 132 peer-reviewed articles, 7 book chapters, and co-edited a quick guide for pediatric retina in Springer in 2021. Today, sir will be speaking on challenges in the surgical management of uveal effusion syndrome. So over to you, sir.
Thank you very much for that kind introductions. And I want to thank Dr. Sethi for the kind invitations. And it's exciting to participate at this Penn Ophthalmologica 2025 in celebrations of the World Sight Day. And it's particularly seeing all the familiar faces and share the screen with our colleagues here. I'm just going to just move my... Okay. All right. Can you see my PowerPoint okay? Yeah,
Yes.
thank you. So, so I'm going to talk about different cases, somewhat unusual cases that I've managed in the past, and particularly on this, I'm going to talk about this interesting 46-year-old woman with 6 weeks of decreased vision. She had past history of nanophthalmus and glaucoma, and she was started on oral prednisone a couple of weeks ago for treatments of exudative retinal detachment. And she's also being put on topical timolol drops for management of glaucoma. Here's the clinical findings. Vision is 2100 in the right and 2400 in the left. The intraocular pressure slightly elevated in the left eye. It was interesting that she has a +16 diopter hyperopia in both eyes. The anterior semi-examination showed a shallow anterior chamber with a patent peripheral iridotomy. And the anterior chamber itself is quite quiet. And the axial length on A scan was 16 millimeter. So it's quite short. And incidentally, there's also choroidal and retinal detachment, more so in the left side than the right. So here's the fundus photograph. You can see in the right eye, the posterior pole is pretty good. There are a little bit of folds in the macula. In the far periphery, though, there's a shallow subretinal fluid with serous detachment. In the left eye, there's a more bolus detachment with macular fold. And here is the forcing angiogram. The top right is the right eye, and the rest is the left eye, showing the serous detachment, but no leakage in the vessels and nothing leaking in the posterior pole that indicate such as leakage or other types of inflammatory conditions. So over the next 3 weeks, the vision in the right eye stable at 2100, but the left eye decreases to count finger. You can see that the more bolus detachment. And interestingly, in the lower frame of the Carlos fundus photograph, there's this leopard spot of RPE changes in the top or the superior part of the retina. So we have a progressive exudative retinal detachment despite systemic steroid treatment. So this patient has the diagnosis of uveal effusional syndrome, which is a rare eye condition. Essentially, the problem is that the fluid collected in the suprachoroidal space, leading to the detachments of the choroid, the cerebral body, and the retina as well. And it's thought to be associated with the increased scleral thickness and is seen quite frequently in the patient with nanophthalmus. About 2/3 of the patients are bilateral. Systemic treatment usually started with steroid and sometimes immunomodulators, with some benefit and some improvement in some cases. And unfortunately, about 50% of the cases actually require surgical management. And the surgical management, the principle is to try to reduce the scleral resistance because of the increased scleral thickness to allow the fluid to leave from the suprachoroidal space. And there are different surgical approaches, such as full thickness sclerectomy. So they make a cut and remove pieces of the sclera to reduce that scleral resistance. And people also have done surgical decompressions of the vortex vein, and again, to try to reduce the resistance for the choroidal fluid to exist. Like everything else, I think Don Guess has been an expert in explaining some of the mechanisms and surgery for those conditions. So this is just one of kind of the explanation that Don Guess has explained because of the thickened sclera, and that causes congestions of the vortex vein, and you get back pressure and transudation of fluid. And there's also the impermeability, the transscleral outflow, the fluid and protein accumulate in the choroid because of that tight sclera. And in addition, there may be associated dysfunctions of RPE mechanism, then you get subretinal fluid accumulations. So here's a surgery that done a little different than the one that was described by the sclerectomy. So this is a sclerotomy without sclerectomy. So after exposing the sclera, it cut down to the through this full thickness sclera wall to the uvea is done. But instead of taking out the sclera, pieces of sclera, we just creating a window, a sclerectomy window. And the idea is not to enter into the uvea, but creating a full thickness scleral kind of cut down with a flap, essentially. And you can see once the that scleral flap window is created, you can see the tension that you have. You can see the gaping of the scleral cut down. And it is done in all 4 quadrants. An additional thing that you could notice is when you cut through to the full thickness sclera, there's small amount of effusion that leaks through. So the suprachoroidal fluid is actually not that much. Most of the fluid is actually in the subretinal space. And in this case, we don't drain the subretinal fluid and we let the subretinal fluid to absorb slowly by itself. And we also don't stitch the scleral flap. This is not my technique. It is a technique that well described it back in 1999. And here's a schematic showing, and they show 5I4 patient did very well, despite that they were refractory to systemic steroid pre-op. And so this is my patient. So 1 week post-op, the vision in the left eye improved a bit to 580, but 1 month later, the fluid continued to recess. And then 6 months later, everything settled down and go back to 2100 vision that was before the exudate detachment has involved the macula. So the advantage of this surgical technique compared to other published technique of sclerectomy or removing of the full thickness scleral tissues is that this allowed the surgery without actually taking away scleral tissues, which can associate with complications of like accidentally cutting the vortex ring and bleeding, etc. And this is also technically easier. And other technique, sometimes using the Kelly punch to limit the amount of scleral tissue removal. And just in case you need to go back, you can go back to the same incision without having to create additional dissections. Some helpful tips about this surgical technique is that, as I mentioned, during the surgery, there's a small amount of suprachoroidal fluid is drained, but that's not the intentions. The intention is to release the tensions of the scleral wall, and we don't try to drain the subretinal fluid and allow that fluid to slowly absorb by itself. It will minimize any bleeding and any trauma to the uvea or the retina. And the choroidal retinal detachment may take months to resolve, so be patient with this. And lastly, there's no need to suture the sclerotomy site in these cases. And who should be offered this type of surgery? Patients with nanophthalmas with abnormal sclera, especially with the exudative retinal detachment. And even in patients who are non-anophthalmic, but they have this abnormal thick sclera that you can identify on the ultrasound. And obviously, if the sclera is not the pathology, then this will not be as effective. And the A-scan feature, like if they have a very short axial length and high grade of hyperopia, is one clinical feature that indicate that good response to this scleral surgery. And the presence of choroidal detachment, exudative detachment, obviously is the main indication for this. Thank you very much for your attention. I'll stop sharing.
Thank you so much, sir. Indeed, it was a very nice presentation. Sir, just wanted to ask you, as this patient had a bilateral presentation, but the left eye had more, what happened about the right eye? Did it resolve with the steroids that you had given, or you had to?
Yeah, fortunately, the right eye, she only has peripheral subretinal fluid. In fact, none of the picture that I share capture those. And with time, they actually settle down. And I think that could be just time or with the systemic steroid. I'm not sure because the systemic steroid did not work for the left eye. Perhaps though, the left eye pathology more advanced, despite of the fact that the axial length as well as the hyperopia is quite similar between the two eye. I think there are probably features that we don't always able to identify that differentiate between the eye. One of the feature maybe there may be despite the thickness, the uveal, the choroidal flow may be different between the two eyes, and right and left could be one factor for the different presentation between the two eyes.
Okay. Thank you, sir. So also, I just wanted to revise the indications for draining. I mean, for these cases, are they like if they are not responding to steroids and if the vision still deteriorates? Are these your indications for the surgical drainage?
Yeah, absolutely. I think one should always do the conservative approaches first, and I think systemic steroid is still acceptable and reasonable to try because there are patients who respond to that. And I think surgical approach, despite that the fact that we are good surgeons, should be one that taken with serious consideration because of the risk of complications.
Yes, sir. Yes. Thank you, sir. Does anyone have any questions for sir?
Yeah, Dr. Lam,
Hi.
congratulations, great cases. And I want to ask you about the sclerotomy, the cut. How extensive you make it? Is just local, or you make a little larger, and because that might increase complications. But if you make it very short, maybe better. I don't know. And the second question is that on those cases that you have to wait for the detachment and the choroidal detachment and the retinal detachment to settle down, do you use intraocular gas or you don't use it at all?
Thank you. Good to see you, Hassan. And always you have very good questions. And in terms of the technique, this scroll flapped window is about 4 millimeter by 2 millimeters, and is in each quadrant. And the key is to avoid any area that is close to the vortex vein, and because that's the main complication that you could accidentally or inadvertently damage the vortex vein, and that can cause bleeding and internal hemorrhagic choroidal. It is a full thickness cut down, so you have to take cautions not to enter the uvea. Interesting, though, the uvea itself, unless you pushed with the knife, relatively resistant. They are not that easily to cut through. I don't put in any intraocular tamponade gas or others, and I let time to do the healing, because once you decompressed the scleral wall, then you will allow improved uveal choroidal blood flow, and the fluid will now have the opportunity to egress through the vascular drainage system. And so I try to do less, and I think the outcome for that reason will be much more, it's better without sometimes a complication related to the additional procedure.
Thank you.
Thank you, sir. In interest of time, we'll move ahead. So I would like to call the next moderator, Dr. Avnish Pandey, sir, to carry on the next session, please.
Thank you, Dr. Anjali. And yeah, so our next speaker is Dr. Andrea Cardenas. She's from Guatemala, and she's a brilliant vitreoretinal surgeon with a passion for innovation. in vitreoretinal surgeries and macular disease management. She practices at Visualiza Eye Clinic, a hub center for advanced ophthalmic care in Central America. She will be sharing her insights on groundbreaking approach to optic disc pit therapy, a topic I think which perfectly reflects her forward-thinking clinical mindset. Let's welcome Dr. Andrea. Over to you, Dr. Andrea.
Morning.
You are
Be here again
yeah.
on this very special day for. Can you hear me?
Yeah. Yes, ma'am.
Okay. So I'm gonna be sharing my screen. Can you see my screen?
Yes, ma'am. Can you make it full screen? Yes. Yes.
Yes.
Yeah. Yes, ma'am. Can you make it full screen, ma'am, please? We can see the slides. So if you can make it full screen.
Yes, of course.
Absolutely, ma'am. Okay. You can go ahead, ma'am. You can go ahead with the presentation. Let's see.
Ma'am, click on full screen, please. In the right top corner, ma'am. Yeah, Dr. Andrea.
Can you unmute, ma'am?
Yeah, please unmute yourself.
Hi, I'm sorry. Can you
Dr.
hear
Amrit sir,
me?
please unmute yourself. Yeah, we can hear you, ma'am. Please go ahead for
Perfect.
share screen, ma'am.
Okay. I'm sorry.
Yeah, we can see your screen, ma'am. Now go to your slide, ma'am.
Can you see my screen?
Ma'am, your internet is very low, so please stop your video. That would be increase your bandwidth, ma'am.
Perfect. I was talking about the hypothesis. There can be vitreous traction.
Ma'am,
Okay.
cannot see your slides.
Can you hear me now better?
We can hear you better, ma'am, but the slides are still not visible.
Hi, can you hear me?
Yes, ma'am.
The
Now
slides are not there?
the first slide has, I think, has just.
Yeah, ma'am. Go ahead, ma'am.
Yes?
Yes, ma'am.
Okay. Can you see my slides?
No, again, the slides have. Now it is there. Now it has come back. It's come back onto the screen. Yes, ma'am. You can start.
Can you see them?
Yes, ma'am.
Okay. So I was talking about the vitreous traction on an optic disc pit. We all know that there could be vitreous traction, and this could lead to the pit. And we also know that we can have also, there's another hypothesis about direct communication between the subarachnoid and the subretinal spaces. There have been cases where silicone oil can be seen in, there's intracranial migration of silicone oil through the optic pit. So the treatment with an optic pit, there has been a silicone lacrimal plug. We can also see amniotic membrane. We can use amniotic membrane. There have been uses of micropulse laser also. A macular buckling can be also done. And also with the inverter internal limiting membrane flap. Here, I am gonna be talking about the use of an absorbable collagen lacrimal plug. This is a case of a 24-year-old female that had 3 weeks of bad vision in the right eye and was previously treated with oral steroids for central serous chorioretinopathy. Her visual acuity was counting fingers in her right eye and 20/25 in her left eye. This is before the surgery. You can see she had a central macular thickness of about 1,500 microns. And you can see the liquid and in the subretinal fluid and the neurosensory detachment. So I did a vitrectomy on her. I wanted to try to help her. So my plan was to put a silicone plug in the optic pit, but unfortunately at that time we didn't have one. We couldn't get one really fast in our clinic. So what I did was an inverted limited membrane flap. And at the time, what I did was I inserted a collagen plug in the optic pit. And after that, I did the inverted flap over the optic pit also. This is 1 week after the operation, and you can see the subretinal fluid started to absorb. There was 800 microns in her central thickness. This is also 1 week. You can see the gas bubble, and the pit. This OCT is 1 month later. In that time, she had also the subretinal fluid was absorbing. The collagen punctum plug was still in place after a month. This is also another picture of that. I did 6 months later. I followed her every 3 months until this July. But 6 months later, I did an OCT on the optic nerve, and I could see that the optic pit was closed. There was no communication, and the collagen punctum plug was absorbed. It wasn't there anymore. This is July this year, almost 10 months after the surgery. She has a visual acuity of 20/100. She's very happy. The subretinal fluid hasn't absorbed all of it, but as you can see in these OCTs, it is absorbing compared to the first month to this July. It is absorbing slowly, but absorbing, and the patient is happy also. Just wanted to say that today, in our clinic in Visualiza here in Guatemala, we're donating 500 cataract surgeries to help everybody. Thank you very much.
Thank you so much, ma'am, for this very interesting surgery and very nicely done. I think it's a very difficult surgery to deal with when we actually go in and operate. And a couple of things which, ma'am, I would want to ask or discuss with is, do you actually think about doing this collagen plug for all your cases, or do you want to do it in some selective cases? And do you actually do a pre-op OCT assessment, whether to see the amount of pit and the corresponding plug, the diameter of the plug, so that if the pit is actually big, whether that would be helpful, or invariably you would want to use this as the first line of treatment?
I wouldn't use it as a first line of treatment. I had to use it because I spoke to Dr. Kakan, who is a great retina specialist in this field in optic pit, and he helped me, and he advised that I should use a silicone punctum plug. But the thing is that time, and it was too much time to have it here in Guatemala. So that's why I used the collagen.
Ma'am, when did you actually?
But I wouldn't. I could.
Yes, ma'am. Please
Yeah.
go ahead. Please go ahead,
No,
ma'am.
I of course I will use the silicone one, but I'm thinking this is an opportunity to see that there are other alternatives to treat the optic disc. I haven't found, and if anyone in the panel has found or does find an article about optic pit maculopathy treatment with a collagen, please do share, because I'm thinking this is an alternative for the optic pit maculopathy.
Yes, ma'am. Ma'am, one more thing. When you are actually inserting the plug into the optic disc pit, when did you actually think that this is it? Or if in case there was a chance that you were initially struggling or maybe adjusting to the pit, and then you inserted it. So to what depth are you actually going in to actually put the plug in? Or has then been whether the plug has actually moved or has been displaced? Do you have any experience, or maybe you can share some knowledge as to how to go about and plugging it into the pit?
Well, honestly, this is the first time I do such a case, and I didn't know how much I should insert the plug. So it was just sensing it. And for 6 months it was in place, but right now I don't know if it's dislodged. The thing is that she still has her lens, her crystalline lens, and there's no cataract. So I'm thinking maybe it's absorbing and I can't find it, or it's lodged somewhere in the pars plana.
Okay, ma'am. Thank you. Anyone from the panel and the speakers, if they want to add for this discussion?
Hi, it's Wei-Ching Lam. Dr. Andre, that was a very interesting and fascinating surgery, and amazing result. I just wonder,
Thank you.
I mean, it's quite clever to use the absorbable plug, and of course, the optic nerve pit has different sizes, and some very small, and some can be generously enlarged. And I think in your case, the size were kind of ideal for the plug because it's actually a good size. Because I always worry when you try to plug the optic nerve pit, you actually could damage and enlarge the pit. And it's interesting that 6 months later, the pit closes. So that may go with the mechanism, such as there may be some trauma related to the insertions or the presence of that plug causing inflammations, and then that may have led to the subsequent closure of the tissues close to the pit, and that allowed the like stopping further egressions of the fluid in the subretinal space. But I think the use of the absorbable plug, collagen plug, is quite interesting. I have no experience in it. I'm just commenting it. Yeah.
Thank you so much. Yes, I also think that all the tissue, all the inflammation helped not only with the plug, but also the inflammation that it caused helped to close the pit and keep it closed. Right now, I mean, I didn't know how much time it will last in there, and it lasted 6 months. I'm thinking it lasts maybe the time that it lasts in our lacrimal ducts. Thank you so much for your opinion.
Dr. Lam, what about that TZIL glue that you used for some cases that you presented, in some retinal programs?
Yeah, I think the problem with the TZIL is that it disappears quite quickly. After about 1 month, it's gone. And TZIL is very gentle. Basically, it's a solutions, plasma and serum that you place, and you place over the pit. So it doesn't cause any inflammations. I think the mechanical insertions of those plug actually cause some bleeding and sometimes just the kind of trauma to the pit, like intentionally, but it actually may have this kind of lasting effect, and the TZIL doesn't. And so I have cases when the TZIL plug disappear, the pit comes back. Sorry, the detachment comes back. So that is not a lasting solution. If you put, I think some of the cases I end up putting like scleral tissues into the plug and then put the TZIL, then that works because the scleral tissue create a local inflammation, I think, and then it will give you a permanent closure or lasting closure.
So,
and have you used? I'm sorry.
Please.
Have you used amniotic membrane, or anyone in the panel has any one of you have used amniotic membrane?
Yeah, I think amniotic membrane also works, and amniotic membrane does cause some local fibrosis. We have those experiences with macular hole closure because I think it creates some kind of tissue reactions underneath it. So so I think it may it works on a small hole. If not, you have to actually plug it. And so yes.
Yeah, I have a case this year also that I used on recidivant macular hole. I put amniotic membrane and it closed, but it dislodged. So it's floating in there, but the patient is happy, so he doesn't mind.
Yes.
But and his vision is better. But I'm guessing maybe for us here in Guatemala, it's also an alternative to use it in an optic pit.
Yes, I think it's a good choice, especially for the smaller hole when you can like put the plug in and
okay, like tuck it in it.
yes. Now you can put the amniotic membrane covering the pit, the small pit.
Yes.
But you cover the macular hole.
Yes. Thank you.
So just to wind up with everyone, I would want to ask the panel, each of you. So for a optic disc patient, the first option for you, if you don't have a plug or something like that, do you prefer the conventional technique of ILM peeling and putting a scaffold over the optic disc, or just leaving it doing an ILM peel? Secondly, in these cases, we do have a SRF and the fovea tends to deroof. So do you actually plan on doing a fovea sparing peel? So ma'am, with you, what would you prefer as the first line of treatment for all these sort of optic disc pits? Would you actually start with putting plugs, or do you would go with the conventional technique and putting a flap, or without the flap and sparing the fovea, or without sparing the fovea?
I think it depends whether you have a macular hole. If you have a macular hole, you can spare the fovea, but I would use the silicone plug and with inverted flap.
Dr. Lam, so your take on it?
I usually conservative, so I start off with just the vitrectomy, drain and laser around the maculopapular bundle where the pit is, and see what happens. If they fail, then I would do, as you suggest, foveal sparing, flap, inverted flap covering the pit. I agree with you. I think that there is a real risk of deroofing the fovea. If you remember seeing those OCT with a very thin roofed. So I think peeling the IOM over the fovea with the thin roof at risk. And then now you change it into a different pathology. And so I don't, I'm just conservative. That's all. I think it's wonderful to see how well the plug does, but I just don't have the experience with it. And I usually, from the next step, I will use amniotic membrane if I fail with the inverted flap.
Dr. Tariq, sir, your take on this?
Yeah, I have few experience using this this ILM over the peat, and I did the laser around the peat, and in one case it worked very well. I never used this plug, so I don't have that much experience. But you told that I will do fovea sparing, ILM peeling, and that ILM I'll take and to the pit. That will be the best option for myself.
Dr. Hudson, sir, your take? Dr. Hudson?
Oh, yeah.
Yes, sir.
Well,
So what
yeah,
would...
in this case, my opinion, I would be more conservative as Dr. Lam. So I would just do it the same way.
Okay, thank you so much, sir. And thank you, Dr. Andrea. It was great and very interesting case. And congratulations again for that contribution you're doing to your city. Thank you so much, ma'am. Thank you.
Thank you, all of you.
Thank you. So over to Dr. Devendra. He'll be moderating the next talk. Thank you. Thank you so much.
Thank you.
Good evening, everyone. It is my absolute honor to call upon our next speaker, Dr. Tariq Raza Ali. He is senior vitreoretina surgeon from Dhaka, Bangladesh. He is associate professor in Bangamandhu Mujib Medical University, Dhaka, and he has authored and co-authored multiple retina research papers. His area of interest mainly is retinopathy of prematurity, but today he will be educating us upon the management of giant retinal tears, strips and tricks. Over to you, sir.
Thank you very much. Probably you can hear me and you can see my slides.
I can hear you, sir, but slides are yet not visible.
But I have given the slides. You can't see my slides?
No, sir, no.
Can I do? I have given my slides in the slideshow and I have shared. It didn't go?
No, sir. Your video is only seen. Maybe you can unshare it and share it once more.
Yeah, Devendra sir. Hello.
Yes,
Hello.
yes.
Yeah, may I help you, sir?
Yes, yes.
Please.
Sir, click on share button, then double click on first option is screen share. Sir, click on share button at the bottom side. A window will pop up.
Yeah, I did that.
Yeah, then double click on first option under the entire screen. A screen or desktop is showing, sir. So double click on that.
Can you see it right now? No.
No, sir.
No, sir.
Sir, on the Zoom, can you click on share button, green color button?
Yeah, I shared this one. Then share.
Then
it is telling open system settings and cancel, allow Zoom please.
allow कीजिए sir. Click on allow Zoom to share screen, sir.
Yes,
you
I
are
did
on
that.
Mac, sir.
Yeah, I am on Mac.
So that's why. So in the Mac there are the security reason. For the security reason, you need to allow to Zoom for share screen, sir.
Yeah, open system settings. They are telling.
Yeah, open system setting.
Yes. Then Zoom.
Then give the permission to Zoom, sir.
Yes. Can you see right? That is probably it is. I don't know whether it is working or not. I'm sorry. So what can I do right now? I'm sharing and it is going.
Now we can see your screen, sir.
Yes, sir. Yes, sir.
Now we are able to see.
Now, yeah.
Now we
Yes,
are
sir,
able
yes.
to see.
Go to in slideshow.
Now,
sir.
yeah, I'm sorry. I've taken much time.
No issues, no issues.
So, greetings from Bangladesh, and it is late night here, about 10 o'clock. My topic is actually you all do these things, nothing new here, but I just want to share my experience here. There is no conflict of interest. We know what is giant retinal tear. I will not go in detail. That is full thickness circumferential tear more than 90 degree, usually not invariably associated with vitreous detachment. Can occur spontaneously, but often is associated with some conditions like Marfan syndrome, Stickler's syndrome, Ehlers-Danlos syndrome due to trauma. Usually it is unilateral and incidence is very rare, not so much, but male preponderance is much more, around 72% are male. So what is the pathogenesis? The pathogenesis is liquefaction of central vitreous, which causes peripheral vitreous condensation and concomitant traction at the vitreous base, usually in the posterior vitreous base, which causes rolling of the anterior retinal flap. Management actually, it became very much helpful after the invention of perfluorocarbon liquid in 1987. Other options are laser photocoagulation, scleral buckle, what I told, primary vitrectomy with PFCL, vitrectomy plus buckle, or combined phaco plus vitrectomy. Laser you can do when the retina is attached and age of the tear is treated with 2 to 4 rows of photocoagulation. Scleral buckle we can go for if the age is not inverted, and it is a good option in children if we want to protect the lens, and supportively we can do cryo or laser. And what we usually do, personal vitrectomy, perfluorocarbon liquid, and then catch tamponade or silicone oil injection. The surgical techniques is very similar in all cases, and you see this is a case where we did, this was a case of that is giant retinal tear. The main thing is it is very important to do the meticulous pars plana vitrectomy, thorough removal of all vitreous from all parts of the posterior segment, and at first from the posterior part of the retina where the retina is folded, then go slowly, and then that is your assistant will depress, and you see we can shave the vitreous very nicely, neatly from all part of the retina. And we have to search for any other break is present or not. You see there is a break here, and there is a break here other than retinal, that is this break of that is our giant retinal tear. There are another breaks can be there, so we have to search for those breaks. And after all removal of the vitreous, you have to come to the anterior part where the anterior vitreous is closely adherent with the that is anterior part of the retina. We have to trim that anterior retina, or we have to cut that anterior retina to remove the vitreous. Otherwise, there may be retinal redetachment. So after thorough removal of all the vitreous, we can unfold this retina with our soft-tipped cannula or with our this or that is our cutter. We can remove this that is retina. We can unfold and we can put perfluorocarbon liquid here over the optic disc at first, and actually very carefully, that is it should be one bubble. There should not be that is much bubble and fish egg formation, and our infusion cannula should be upper side so that there should be no egg ball configuration. After putting this perfluorocarbon liquid and up to the anterior part, that is up to the lens, then retina is attached. Now laser is applied 2 to 3 rows up to the ora. Very good laser should be there. The main trick is actually when we go for PFCL silicone oil exchange. I always do PFCL silicone oil exchange. I prefer to do this other than PFCL, then air exchange, then silicone oil. I do PFCL and silicone oil exchange. I feel it is comfortable for me, but we have to always keep this soft tip cannula over the break so that there is no slippage of subretinal fluid, and you can that is retina can be attached. This is another case. You see this is not only giant retinal tear, this is 360-degree retinal tear, and retina it is 11 years old girl, and you see the PVD is not induced. We had to induce the PVD. It was not very easy because retina was very that is movable, but we could do the PVD induction nicely. And then the other work was very simple, that after this PVD induction, we removed the vitreous as much as possible, then put the PFCL to strengthen the posterior pole. Then we removed the anterior vitreous, and that after removing the anterior vitreous, then we put in more PFCL, and retina should be flattened with the PFCL more and more up to the lens. You have to put the PFCL. And again, to remove the anterior vitreous, you have to remove the anterior vitreous from the anterior edges of the retina, that movable retina, mobile retina. We have to cut the retina to remove the anterior vitreous from the retina. Then put silicone oil again and again, and retina becomes atrophied. Now I'm cutting the anterior part of the that is folded retina. This rolled over retina is cut by the vitreous cutter, trimming the rolled part, which is not unfolding by PFCL. After putting this PFCL, then task is like this, that you do PFCL silicone oil exchange after doing meticulous laser. After laser, then again PFCL silicone oil to directly exchange, and it helped the retina to be atrophied. So this is not very easy, tough procedure. We all are doing this. But if epiretinal membrane is formed and star folds or macular holes are present, we can do ILM peeling. But before ILM peeling or before putting the PFCL, we have to stain the retina. That is a trick, that you have to put the staining of the dye, that is our brilliant blue, before the PFCL. And laser is applied to the corners and edge of the tear. This is very important because vitreous is very much adherent in the corners. That can cause redetachment. And fluid air exchange we can go for if we want to put this, not silicone oil, but gas. If you want to put gas, then we can do fluid air exchange and then gas aspiration. In phakic eyes, we want to preserve the lens, and then you can use the chandelier illumination. Advantage is it is accurate lens calculation is not done, and disadvantage, it is technically really difficult to clear the anterior vitreous and retinal flap, that is because there is every chance to touch the crystalline lens. And somebody prefers to do the phaco along with the posterior segment, that is posterior chamber intraocular lens implantation. Advantage is easier access, but disadvantage is it is an extra procedure, and there may be the calculation of the intraocular lens may not be accurate. PVR is not uncommon. It is present in around 50% of cases. Proliferative vitreoretinopathy is usually with trauma and chronic cases. And if we want to do that is in these cases, I will go for 360-degree belt buckle, encircling buckle in these cases, and then remove the subretinal bands at first, and then put the PFCL, then go for epiretinal surface membranes after the PFCL injection. Then that is the procedure is same, that after putting the PFCL, go for laser and then PFCL silicone oil exchange. So in conclusion, I can tell that GRT, sometimes it may be a complex situation, though it is not very tough surgery, but sometimes it is very complex, and it may be a blinding condition. It needs early treatment, and modern vitrectomy tools and techniques are helping us. That is wide angle viewing system, chandelier illumination, and PFCL has made our life easy to manage these cases. Thank you for your patience hearing. Thank you very much.
Very
Great
educational.
presentation, Dr. Tariq. And I would like to ask you some couple of questions. I finally found somebody that does surgeries pretty much the way that I do. So I do exactly what you do. And for giant retinal tears, and of course, we have to search for the peripheral vitreous and, if necessary, do retinotomy as you did, because otherwise the retina would fold on itself. And the perfluorocarbon liquid should be instilled inside the eye very slowly in order for us to avoid those bubbles that you mentioned. And one thing I do exactly like you, and I think it's very important to do the direct exchange from using perfluorocarbon with silicone oil. In this way, you prevent slippage of retina, as you did. So you go slowly and you do a more controlled exchange, and it works better. So you don't have the dislocation of the retina and all those problems that we see in the postoperative periods when you do the angiography, when we do fundus autofluorescence and the vessels don't combine. So in this way, you prevent all those things, because a giant retinal detachment, the retina is already dislodged. So the aim is to put it back where it was. And for the perfluorocarbon and the trimming is that I mentioned, and if you have concurrent holes or epiretinal membranes, and maybe you would peel, as you mentioned, you would go on with the surgery doing an exchange and maybe dyeing with the brilliant blue to pick up the epiretinal or internal limiting membrane tissue. That was amazing to hear that from you. And another case that you commented for about this PVR. So we have to take care of the PVR before we do the retina
Excellent.
surgery. Yeah, because otherwise then the PVR would prevent the retina from attaching. So amazing cases, and congratulations for you. And somebody might ask more questions by now, but I want to congratulate you, Dr. Tariq and Dr. Andrea, for being to Retinosome session for the first time. So we created the Retinosome session, and Dr. Vaibhav Sethi reproduced the retina in Ophthalmologica this year twice. So it's an honor for us. So you are representing Bangladesh, and Andrea representing Guatemala. So it's an honor for us to have you in this Retinosome special session.
Thank you so much. It's an honor for me also.
Yes. Thank you very much. This is the first time I have come here, and I must thank Dr. Vaibhav Sethi to invite me here. And I have learned so many things this evening, not only this session, in this hall. I'm watching all the presentations from the evening. So many beautiful presentations I have heard. So many learnings from me from these sessions. And for this, that is giant retinal tear management, actually, for the beginners, it is not very easy that during PFCL silicone oil exchange, there is every chance of slippage. So that is the prevention of slippage is the most difficult part of this surgery. Otherwise, it is not very difficult surgery, as I feel.
Anybody has any more questions from the panel or comments? If not, Dr. Anirudh, you can take over for next talk.
Thank you very much.
Thank you, Dr. Tariq. Thank you, Dr. Devendra. I now invite Dr. Hudson for his talk on the ILM seal technique for chronic macular hole with retinal detachment. Over to you, sir.
Thank you very much. This case, I started doing the stuffing technique as well as other techniques for macular hole surgery. But those cases, they're getting successful every time I present them. So I will show you my screen over here. And let me make it bigger. Yeah, that's it. And I also want to thank everybody in the panel for being part of Retnosome. So really honor for me to be in panel Ophthalmologica every year. So since many years, it's very good for me. And for Retinal Society as well. So I've got no conflicts of interests. So I'm just displaying this slide that because this technique I first presented in Cordoba in Argentina, this technique with a retinal detachment in 2023. And I showed the case there and also at the BH Summit here in Brazil, Belo Horizonte. And but we did not have the results as of yet. And then after doing this surgery and following some patients, and this patient especially, I introduced this technique. My first publication of this technique was in the iTube channel. The patient had visual acuity that came from hand motions to 2000 in the very chronic macular hole with a retinal detachment at the same time. So what we did is a very interesting technique that we plugged the ILM just like that. There is a difference when you plug the ILM just a round thing inside the macular hole as opposed to this technique. You are like embracing the macular hole. And so these two stalks that you have attached to the circular part of the ILM, they actually contract and make the macular hole close. So this patient is a phakic patient, 68 years old, chronic 1-year retinal detachment with a macular hole, vision hand motions, and the surgery was September 13, 2023. And we have here the technique. This is inverted vitrectomy. So I will advance a bit the surgery so that we go it a little faster. So that's the technique. So the patient is phakic, has some cataract, but not much. And interesting, so like it was 2 years ago, patient was 66 years old. So now he's 68.
In the affected eye.
And you see the detachment there is a large and bullous one, and also has some PVR at the retinal periphery. So the first thing, because it was, like over 1 year of a retinal detachment, I just did a very peripheral retinotomy there. So after I did the retinotomy, the retina was starting to settle down and to attach. And the thing is, the retinotomy was very peripheral and small as well. We did the surgery preserving the lens all the time. And like Dr. Tariq said, we have to be very careful sometimes, even when we inject very slowly the perfluorocarbon liquid, we come up with those bubbles. So we have to do our best to avoid them. So now moving on to the retinal periphery, we removed all tractions, all vitreous around, and guess what? Now I'm removing some of the perfluorocarbon liquid that I put first to withdraw the retina from the center and avoiding to detach the macular area. So now I'm removing all bubbles possible. So I kept the retinal detachment very peripheral, so it's not threatening the macula anymore. Just, we have to avoid, you see these vitreous that you mentioned before in your surgeries, Dr. Tarek, they keep appearing there. The vitreous, we have to remove them all. So even those small bubbles to avoid them from proceeding towards the macular hole. And now, because it's necessary for staining, my point of view, to do a complete air fluid exchange. I did this right now, a complete air fluid exchange, a very slow one, also to avoid the retina from dislodging. And now I can use the brilliant blue without the vitreous below the air. So keeping the lens there, so a very good staining. I kept removing all vitreous adhesions at the periphery when we cannot go too far, otherwise the lens could be hit. So now after the ILM is stained, so I put perfluorocarbon liquid back. And now what I'm doing, I'm removing the ILM, and after removing the ILM, it's not going to escape. The ILM is going to stay there. It's not going to escape off the macular area, because a good thing is that perfluorocarbon holds it still, and you have, like you get some ILMs around the macular hole, and you put them aside, as you see. And the interesting thing is that the surgery could be finishing just like that, doing laser for the detachment and doing the good work for the macular hole. But now I'm moving the ILM towards the hole. As I said, this round part of the ILM I put right there inside the hole, and you have two arms. And with these two arms, you contract and like embrace the hole and keep the hole covered, and the tension from the contraction of these two arms of the ILM, the way it's built, they're going to make the hole close, as you're going to see later. And now I'm taking care of the retinal detachment at the far periphery. So you see the ILM is there. That positioning of the ILM makes the hole still, I mean, the ILM still, and it doesn't detach. I'm doing a little more of retinal peripheral work, completing the retinotomy because of the peripheral PVR. So relaxing a bit more. And now coming to the end of the case, as you see here, after removing the perfluorocarbon liquid with a very slow air fluid exchange. You see, I'm using a little more perfluorocarbon liquid to withdraw the retina from coming, because now I relaxed the retina. And the last step of the procedure will be the exchange. Let me advance it a little bit. So I do more laser by doing that. Patient is faking. The last step of the procedure is, after taking care of the retinal detachment and making it very peripheral, I do the last air fluid exchange. Now it's going to be this final step of the procedure. And because the retinotomy was not so large, and I removed all the perfluorocarbon liquid like that, I decided to end the case without using the silicone oil, and the retina got attached. And this was amazing that we could attach the retina up to the end of the case. And we have the results, we have this OCT from December 2024. You see the retina completely attached. So you've got some very peripheral epiretinal tissue over there, but the hole is closed. The vision got to 20/100, as you see here. So I really appreciate you watching this video. And this is a technique that I follow, and I've been following and doing for special chronic macular holes. I don't think we have to stop like doing the same techniques all the time. So this helps close. I have good examples from that. Thank you very much.
Thank you, sir, so much for your interesting case. I would like to ask you a question. That was the full thickness macular hole the cause of the detachment in this case, or were you able to find a peripheral break as well?
The thing is, the patient had this chronic retinal detachment. And by the time we examined the patient that came from another service, the retina was covered like that. So as you see here in the surgery, the macula looks like it's attached. But we had this edge of the retinal detachments over the macula, so we didn't see any macular hole. So the macular hole was observed during surgery. That's interesting because nobody knew, and the no CT was not performed because the retina was just in front of the pupil that did not dilate as well. As you see, it never dilates 100%. And so we found out that patient had this macular hole during surgery.
Thank you so much. Just another question, sir. In cases in which you have cases with recurrent macular holes, in which in previous surgeries, the ILM has been peeled extensively, and there is scarcity of ILM available. So what do you use to close these holes?
Well, my experience is that I've been indicating some cases like that, even from recurrent macular holes that had already had these ILM peeled beforehand. So I just go very peripheral, I stain, I do everything again, I stain, and I use brilliant blue that stains perfectly. I see everything perfectly. So I get the ILM from elsewhere. So from elsewhere to get and bring the ILM towards the hole, I got to use again after brilliant blue or after any other dye. I like using perfluorocarbon liquid. I use perfluorocarbon liquid. Otherwise, on the transport on the way from the periphery to the center, I will lose it. So perfluorocarbon liquid keeps the ILM still there, and so just keep following up to the hole, and so you leave it there. And if you are able to do this technique and put the round part, the great bulk of the ILM inside the hole and create two arms like that, as I did, and then the chances of closing the hole are larger because the physics would explain they contract like that, and then you've got a successful case.
So, say we are doing inverted ILM peeling for these large macular holes, or that is recurrent macular holes which are not closed for the primary surgery. So what is your comment? Say, if I do the ILM and invert that ILM peeling, ILM over the hole, what is your comment on those things?
Yeah, I like doing inverted technique as well. I've got some cases, and including some cases are in iTube, and I like inverting, and that works as well. But for this case, I decided to do that technique because the hole was large enough and was chronic, and also had a retinal detachment. Another thing I have to think about is that the retina was detached. Since I relieve the retinal traction at the very retinal periphery, the retina might have shortened a little bit, and that helped to close the hole, and that could help as well. So this is one of my thoughts, but I agree with you. I still use the inverted technique, inverted ILM before this technique. This technique I only use for chronic macular holes.
Excellent, excellent. New learning for me. Yeah, I will try also.
Thank you. And we both agree that we use perfluorocarbon liquid. I love, and I have, it's like seeing my surgery on yours for the giant retinal tear. I just published a few months ago a case exactly like that, and that's the way I'm really impressed. We have exactly the same technique. Congratulations.
I think we can move on to the next session if there are no more comments. I thank Dr. Hudson for his talk, and I request the organizing team to move it forward.
Thank you. Bye-bye.
Thanks, Andrea. Thanks for being with
Yes,
Tariq
thank you.
for the
Thank
first
you for
time in the
taking.
Retnosum sessions, and we are honored. We started, this thing in the pandemics with Dr. Lam. So Dr. Lam is the ambassador of Retnosum. So it's really
This is great.
good.
Yes, this is great. I follow you in WhatsApp, in the WhatsApp chat. It is
Oh,
great.
yeah. Thanks.
Great case. Thank you so much.
Thank you so much. Bye-bye, Tariq.
Bye-bye. Bye, everybody.
Bye, Vahab.
Bye,
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 brother.
Bob. Bye.
I can see Vaibhav right now.
Yes.
Thanks again, Vahab. You are awesome.
Thank you very much. Thank you. It was an amazing session.
It's an honor that
Thank
you
you,
organized
Vaibhav.
this session so well. So I'm really honored for everything you do, and I hope to see you soon in India. I'll go
Yes.
very soon.
We'll meet,
Maybe
yes.
visit
We haven't met
Tariq
yet.
as well,
So
because you
many
are not
years.
so far.
Thank you. Thank you very much
Yes,
for
Vaibhav.
all the faculty. Thank you so much.
Thank you for everything. See you in
See you there.
Cancun.
Yes. See you, sir. See you, Dr. Arik. Thank you. Thank you, Dr. Palak. Thank
Bye.
you. Anirudh. Thank you very much. Bye-bye.
Bye.